नमस्कार. Namaskar.
Vanakkam. How are you, sir?
Fine. Actually, you are missing away from me.
I am missing from you.
Yeah, always missing away from me. We'll discuss and then vanish.
No.
I know that you have your own thinking and limitations.
No, we've been going through a bad time. Actually, Sonia's dad is in ICU
Oh
and
my God.
he's had 3 admissions to ICU in the last 2 months. It's not, there have been too many issues happening here. Chalo, we'll chat around.
How is everything? How is everything?
There's nothing. You tell me how things. How's Maldives?
Good. Maldives is occasional visit. Last week in Maldives and Jamshedpur. Before that, I was in Haryana.
When you come to Haryana, why don't you even give me a shout?
No. Last time I was actually in Chandigarh and Ambala only. Ambala, that is, I did not. Just came one night and just stayed and came back. And
How's Manju? How's our magician?
everybody is good. In the morning, I'm lucky to be with all the Delhi people.
You're a big man. Everybody wants you.
No, small things.
Yeah, see, Mediterranean hospitals behind you.
No, actually, all Manju's plans.
Manju is doing very well. I really enjoy her stuff on Facebook.
Yeah.
Very good. I can't understand the Malayalam. I wish I could.
Because actually, the World Women's Day, she was actually one of the person was taken by the media. Just talk about the centers and all.
Very good. One sec, let me just get my slides. I'm supposed to start this damn thing.
Oh, you are the first speaker.
Yeah. Yeah, now I'm okay. Suddenly they'll say, and I'll be looking for the slide set. Suman sir, good morning. Oh, sir, गाला भी दे रहे हो तो सुनाई तो दे दो. क्या हाल चाल?
Yeah, Suman sir.
We are honored with the presence of my dear friend Pratap.
Oh my
Early
God.
morning.
Good morning, sir. Good morning.
Yeah, sure.
Hi, Ripin.
Hello, sir. Morning, sir.
We are starting sharp at 9 o'clock, right?
I hope so.
Hopefully.
I hope so. I really hope so. After that, suddenly Mohit called up and said there is a debate without a debate. I said, wow, that's a new one. Last time we had a debate, the proponent spoke for the opponent also. Because the slides are the same. He says, I can show the same from a different perspective.
Morning, sir.
Morning.
Morning, sir. Good morning.
Hi, champion.
Hi. Morning, sir.
You're working too hard.
Yeah, Mohit is doing
You're
a good
working
job.
too hard and making us work too hard, yeah?
No. Sir, आप लोगों की blessings and it's only because of your presence that content becomes a good success, sir. That's all.
Yeah,
We
but
are just doing our little job.
Arun he's got a Ibis image behind him, as if he's going to run
Arun,
into the
no,
corner.
sir, I tell you, sir, Arun and imaging have become synonymous. So that is.
अरे क्या बात है अरुण? हाँ अरुण, कौन सी इमेज है भाई? अश्लील images मत दिखाना, बस that is all.
Good morning, Dr. Pratap Kumar, sir. Good morning.
Yeah. Good morning.
Pleasure to meet you for the
Arun, you
first
are
time.
muted.
Yeah.
Hi, Dr. Pratap. Hi.
Thank you.
Dr. Mohit.
क्या तुम इमेज दिखा रहे हो?
Good morning. कुछ इमेज नहीं. Imagining, not imaging.
And I call that Bhakti fellow, I call him imaginary consultant, because he's always imagining.
Imagining, not imaging.
Bhai, Mohit, start kare.
Sir, we have almost around about 96 residents and people who are available. Let us wait for 5 more minutes. So you just
Bhai, tumhari problem hai. Your delays get amplified over the rest of the day.
no, sir. Kal hall 2 ran absolutely perfect. We were having a delay of around about 40 minutes in this. Like in Sham ko program went on time. So it was perfect.
Yeah.
Yeah. So I think we wait, sir, and then.
Mohit will be better known as the event organizer.
Anji.
Arey nahi, bhai. Mohit has got many characteristics and many great attributes. He can be anything. He can wear many hats. This is one of those small things that he does.
Yeah.
Tick. Sure. Tick. Thank you.
PG track has been doing good, sir. We are completing 1 year continuous next week.
No,
Sir.
excellent.
Can I just make a small suggestion, Mohit? Also, apart from Zoom, do Cisco WebEx, because Cisco WebEx allows you to make a transcript. And if you make a transcript, we can actually edit it and make something available as a compendium to students.
Okay.
That's a very good suggestion, sir. And I will do it. Actually, the problem was most of the people were finding Zoom as more comfortable, so we chose that.
No, we continue with Zoom. Most of these people who are helping you can make you do multiple platforms.
Surely,
so
sir.
among all the platforms, take one Cisco WebEx as well. So that will become a very important thing, because that can then be transcribed into a booklet or a book, and it can be of and if it's got a YouTube link, so people who want to really listen to the talk can also do it.
Surely, sir. Surely, that's a great idea, sir. I will definitely take a note of it. और इसको हम लोग plan out कर लेंगे, sir. बिल्कुल. Very great. Anurag. Okay, friends, very good morning to all of you. Welcome to the 35th edition of the Cardiological Society of India Delhi branch conference. And we are into the Cardio Prime Hall, that is the Intervention Cardiology Hall. And today, after the great sessions today we are going to start our sessions with imaging and physiology assessment. So imaging and physiology have practically become synonymous with PCI. And today we have our expert panel and great speakers. We have expert panel in form of Dr. R.R. Mantri, Dr. Ripen Gupta, Dr. Ranjit Nath, Dr. Suman Bhandari, Dr. Ashish Govil, Dr. Jamal Yusuf, and Dr. Rajesh Vijayvargiya. So I request our expert panel, Dr. Suman is there, to please start the session and have a great time. Please interact with each other. I only request that if the sessions and discussions can be limited to time, so that we can stick to the time and join the meetings in the afternoon. Thank you and have a great meeting. I'll see you, catch up soon within a minute. Dr. Suman Bhandari, please.
Yeah. So, good morning, friends. We have a very interesting imaging and physiology assessment session, and each talk is for 10 minutes. And the panel discussion is supposed to be at the end. So we can have all the talks and have all the speakers, and then we can have the question, answer, and discussion at the end. So I would like to invite Dr. Dhal for giving his talk on role of FFR and resting indices in multi-vessel PCI. We all know Dr. Anil Dhal, and I'm sure we will learn a lot from this talk. Thank you.
Thank you, Suman sir. And thanks to Mohit. He's got us out of bed early Sunday morning. And I hope we have a great session ahead. So the idea of functional assessment of PCI is as old as PCI itself. And really, if you look back, when Grunzig gave this idea as far back as 1978, he actually, when he was doing the first case, a patient by the name of Dolph Bachmann, a 38-year-old mechanical engineer with a proximal LED, Ek Senning, who was the professor of cardiac surgery, who supported Grunzig, was in the cath lab. And once he saw that there was actually a transtenotic pressure gradient, which was seen before the procedure, which disappeared after the angioplasty, he said, this is going to be the treatment of the future because it is physiology guided. There are only two fundamental questions in interventional cardiology. Should I treat? How should I treat? Or do the best job treating? Everything else actually is commentary. So if you really see, the clinical outcome is determined both by the extent and severity of ischemia, the amount of myocardium which is subtended, and how severe is the disease. The FFR has been a unique concept which has developed over a period of time. We know that there has been a little bit of a war between two warring factions which have been supported by different parts of the industry over a period of time, but it led to some great trials. The DEFER trial told us that non-ischemic lesions do well on optimal medical therapy and PCI can be potentially harmful. This was a transition of the FFR concept from single vessel to multi-vessel disease. And in the FAME trial, we realized that PCI treatment of only ischemic is better than PCI of all angiographic vessels. And then we transitioned from a tool that differs to one that mandates revascularization in FAME2, where we said that the revascularization of ischemic lesions is better than optimal medical therapy. So very clearly, DEFER showed it was safe to leave lesions with an FFR more than 0.75. FAME1 showed treating lesions with more than 0.8 was harmful. FAME2 showed that if you deferred in patients with FFR less than 0.8, it was harmful. So really, FAME2 confirmed the findings of DEFER. And these findings continued to give us results at a 10-year, which was based on actually improvement in mortality, even up to 10 years and 15 years of follow-up. So these are great, robust results, which actually tell us a complete story. But we also must realize that the impact of the myocardial supply area on transtenotic hemodynamics is determined by FFR. And this can lead to a functional angiographic mismatch. I take you back to Tonino's paper about 11 years ago, where he said that a lot of people who had so-called three-vessel disease, who were being referred for CABG, actually turned out to not have three-vessel disease, but have two-vessel or one-vessel disease. And this led to a great cartoon by Songjung Park, where he said that he had been divested of his role as director of Hassan Medical Center because the volumes of work, both in intervention and surgery, came down. But really, we are physicians and we want to impact prognosis as well as symptoms. And we realize that FFR is a marker, which may be a marker of a continuous spectrum. Because if you take a conceptual plot of FFR, it is a continuous marker of risk. And having thresholds like 0.75 and 0.80 may actually be artificial to our understanding of FFR. We do need them to help us decide whether to go in to defer or to intervene. But we must understand that this is a continuous marker of risk. We also must appreciate that there are common pitfalls in obtaining reliable physiology, not using nitrates before, not normalizing, not watching the setup, not weighing the results, waiting for the right time. There are critical steps. You should not take a guide catheter with side holes. It should not be damped. You should have given nitroglycerine. There's an impact of the introducer. Sometimes there are issues on where to equalize or normalize. How far beyond the lesion do we place? We use maximum hyperemia, but how much is maximum? Do we actually check the pullback for the drift? And do we take into account our venous pressure? So all this is something which I don't want to go into, because it is something known to everybody, including all our fellows, know that you have to have a good pressure transducer setup, which is correctly zeroed at the proper height. Guide catheter should represent aortic pressure. And when you are zeroing and equalizing, you should remove the wire introducer from the wire connector, because it can have an impact. There were some issues with maximum hyperemia. Adenosine was a great agent. It was administered, but there could be impacts of caffeine, tobacco, and so on and so forth. And there were other issues which could be associated with which interfere with increased hyperemia. Use of beta blockers, statins, fatty meal, lavender aromatherapy, etc. So there are some clinical challenges. What about stable coronary syndromes? Stable IHD, low risk? Well, FFR works. We have key points from variety of trials. What about STEMI and STEMI? Well, it is still a matter which is sub judice. Vein grafts, we can assess the physiology, but the biology of the vein graft deterioration is critical beyond the ischemia. Ostial and left main lesions are always a challenge, especially not knowing where to equalize the impact of downstream and upstream lesions. Bypass graft failure, early rate of bypass graft closure in non-physiologically significant vessels is known. Serial lesions need understanding, but we have some new tools, and aortic stenosis may actually, and even a TAVR may actually be something which may impact it. In ACS, we know that there is unreliability because of the dynamic nature of the bed and lesion. And as the flow recovers, FFR falls. So we have some clear guidelines today as to where to use, when not to use. What if we hate adenosine? Well, we have some options. And what are these options? We can either look at contrast FFR. We can, and for those who don't know, even instilling chilled saline and just putting in a wire into a branch, and if you see ST elevation is a poor man's FFR, which we have been using. We've actually supervised a DNB dissertation on this. So what about the whole cycle? We can use PD by PA, and there are some techniques like RFR from Abbott, but we can actually use the wave-free period. So what about adenosine? If we have to use adenosine, we must do it right. Check the infusion. We must have a large central vein, avoid Valsalva during infusion, and use correct dose or dilution, and make sure that the guide catheter is not damping. PD by PA is actually the difference in the pressures, and it is a simple and a very elegant tool, but the PD by PA figures are a little different. 0.92 possibly correlates with 0.80. The newer modalities, which could be used in the cath lab or in the CT, which is anatomically gated, is by either using like FFR, which is hyperemic pressure ratio, or some non-hyperemic wire-derived pressure ratios like RFR, or the diastole subcycles, or some which are angiographically derived. We must understand that when we are doing this, we are only assessing the physiology of the epicardial coronaries, but what we need to understand is the entire circulation. The IFR is the instantaneous wave-free ratio, which is the wave-free period when the resistance is naturally constant and minimized in the cardiac cycle. And this has been used by different companies. Either you can use an IFR, or you can use a DPR or a DFR, or the whole cycle with the RFR. And these have reasonable correlations with the FFR and do not require the concurrent use of producing hyperemia like adenosine. The similar traps and errors are there with use of NHPR, which could be equipment failure, erroneous zero, faulty electric wire connection, drift, miscalibration, or procedural, which could be guide catheter damping and chasing basal flow. Very simple, even engaging the guide into the ostium and damping it is a no-no, and you should watch the pressure waveform for damping. There are some other things which you should look as clearly the incorrect sensor position and changing basal flow. But this has been very well validated by a variety of studies. We have studies like the Sweetheart and Defined Flare, which confirmed that the IFR was as good as FFR. This was further confirmed in a non-randomized in Syntax 2, with DFR, DPR, and RFR, we have some good retrospective data. And we also have PDPA data, which is coming from Lipsia strategy, which is an ongoing trial, and Kobayashi's retrospective. So all this is further been extended to an imaging-derived physiological assessment, which can be either a FFR angiogram, a QFR, a virtual FFR, or even a CT FFR. But what we must understand is that an IFR guided strategy may be superior to FFR in terms of cost effectiveness, because it actually decreases the cost of adenosine use. But the problem is that there could be some IFR FFR discordance, which could happen with either reduced CFR or preserved CFR. There could be various factors which could contribute to this discrepancy: left main or proximal LAD disease, very low or very high heart rates, not at extremes of stenosis severity. And this may lead to having to do some more tests to actually determine where we go. But a very vexing problem, which has been pointed out by a large number of studies, is that even after we use FFR for physiological guidance to perform a procedure. But when we complete a procedure, about 25% of our patients do not have adequately performed PCI. And this has been reproduced in a variety of studies. There are a variety of reasons. It could be diffuse coronary artery disease, some unnoticed or neglected lesions, suboptimal stent placement by way of underexpansion, geographical miss, tissue protrusion, malapposition, or some technical issues, or maybe even a large collateral supply to a contralateral CTO. This makes us wonder, are we doing a good enough job? FAME trial showed us that the MACE rate was 13% in FFR guided, which is albeit 30% lower than angiographic guided. And the ischemic perfusion defects persist in about 17 to 36% even after a so-called successful PCI. Let's go back to this conceptual plot of FFR as a continuous marker of risk. Does this also apply to a post-PCI FFR? Yes, it does. And the defined PCI looked at this and showed us that about 24%, now 24% is a huge number. Patients after a so-called successful PCI had a significant residual ischemia when they were interrogated by post-PCI IFR. And unfortunately, all centers did not use concurrent imaging. So this can be a challenge in the results of the defined, but it is a very thought-provoking result that inapparent residual ischemia in 24%, which is a lot. There are some causes which we've already discussed: diffuse disease, geographical miss, inadequate coverage, stent underexpansion, maybe LAD location, serial stenosis, and it was 1 in 4 patients is actually a big number. And this could be modified by attempting to understand whether the lesion was focal or it was diffuse. And if it was focal, 2/3 were proximal or distal to the stent, 1/3 were inside the stent. And this could give us a great window of opportunity for improving our results, and residual ischemia could be decreased from 24% to 5%. But this led us to thinking something else. And Volcano, which is now Philips, actually decided to co-register the IFR. And just like we have a step up in using physiology in the cath lab when we are doing oximetry runs, and also we understand that once we put this an IFR co-registration, we can have advanced physiological guidance to help us decide not just whether to treat, but where to treat. So we are actually looking at doing an IFR of the whole vessel. We identify the precise locations which are causing ischemia, and know each yellow dot signifies a 0.01 drop. And you can do a virtual stenting and determine the stent lengths without need for a pullback device, and you can predict the physiological gain. And what it has shown us also is something very unique, that in this so-called diffusely diseased vessel, if you probably treat only the proximal lesion, you're probably going to benefit the patient much more than making a full metal jacket. So this is a new, shall I say, a move towards precision PCI, which is incorporating imaging and physiology. It can optimize pre-treatment strategies for PCI planning, lesion modification, stent sizing, co-registration, and complete optimized treatment with physiology improved post-PCI without edge dissection, optimal stent expansion or opposition to minimize MACE. So MACE can be actually looked at as very nicely. I saw Arun showing an IVUS image behind him, could actually be mistakes using angiographic coronary evaluation. Further, this is going to be tested against angiographically guided and image guided in the defined GPS trial, which is already finished recruitment, and we are hopefully going to get the results. But as of today, if we have an operator determined angiographically successful result, we have to first determine, was PCI guided by physiology? If so, which tool? Was it PD by PA? Then if it was, we should do a PD by PA at the completion. If it was FFR, again, look for FFR post completion. If it was IFR, if it was QFR, and then you have to identify the localization of drop-in pullback. Focal in stent, you can consider imaging or post-dilatation. Outside stent, consider additional stent or imaging. And in diffuse, we may have an opportunity here with some drugs like PCSK9 inhibitors and other drugs which may actually decrease it. In CT, a similar trial is going on with Hawkeye and also with QFR, and we may actually benefit over a period of time. I don't have time to discuss all of that. To conclude, physiology assessment post-PCI predicts outcomes, but is rarely used. If you look at it, only 10% of cases have pre-PCI FFR, and in them, only 10% further have post-PCI as of now. Pullback can identify stent-related issues, overlooked lesions, and diffuse disease. Focal drops indicate the need for post-dilatation or stent implantation, may be supplemented by imaging. Diffuse disease demands aggressive medical therapy, and we need more powered trials to incorporate this in our daily practice. Thank you very much, and I do hope I have finished in time.
Yeah, thank you, Dr. Dhal. You just 5 minutes over time. So it's just to let the other speakers be aware that there's a time limit of 10 minutes. There's a timer which keeps running. So please, we don't.
Yeah, but I wanted to just tell Mohit that the timer doesn't show in the speaker slide.
Yeah, that is a problem. So that is a problem.
So I was trying to keep a watch, but
I'll then remind the speaker. So I didn't want to interrupt you, but
right. Very generous of you, sir. Yeah, thank you very much.
So we have the next talk by Dr. Nishit Chandra, who's Director Interventional Cardiology at Escorts, and has a keen interest in OCT. And his talk is on MLD Max algorithm in OCT, step-by-step demonstration. Over to you, Nishit. We can't hear you. Nishit, are you muted?
Okay. Am I audible now?
Yeah, yeah.
Okay, so good morning, everybody. And thank you, Dr. Bhandari, for introducing me. And thanks, Mohit and the Delhi CSI for giving me this opportunity. So I'll try to be brief and I'll try to be finishing in time. So Dr. Dhal has already discussed about when should you do it, guided by the physiology. And then if you have decided that the physiology guides that, yes, you should do it, the FFR is positive, then how should you do it? And that is a component, the most important component of the precision PCI. How should you do it? Which is an image guided flow chart for PCI, precision PCI. So how did it start? Basically, my greetings from my hospital, Escorts Heart Institute. If you see the invasive imaging development, it started with angiography in 1958 with a resolution of only 1 millimeter. Came in 1988 intravascular ultrasound with a markedly improved resolution of 100 microns. And now the HD IVUS is even 40 to 60 microns resolution. But the game changer was the OCT, which is have a least resolution, which highest resolution, that is 10 microns. So, and if you remember that the RBC size is 8 microns. So you can even see the small cells, macrophages, cholesterol crystals, And so the OCT has been the real game changer. But we have to do an OCT in a checklist format. We should not be missing anything. To guide this, to arrive at a flow chart, 8 people met at the beginning of the last year, led by Ziad Ali. And these are the Light Lab Consortium, and they formed, they gave the word simple algorithm called MLD Max. The purpose of this MLD Max was to simplify the workflow and give a checklist to the operators, to the new fellows. So they should not be missing any component of the workflow. So the 2 components of this MLD Max is first is the pre-PCI OCT component, which comprises of MLD. M stands for morphology, L for length, and D for diameter. And then once you have implanted the stent, you have to optimize, and these are denoted by MEX. MEX stands for M for medial dissection, A for apposition, and X for expansion. So let me go through by a simple case study. This is a lesion in LAD, proximal LAD. And so if we see the pre-PCI OCT strategy, MLD, so morphology, length, and diameter. So for morphology, you have to understand the different layers of the intima, media, and adventitia. And I'm not going to those details. So, but when you apply the OCT algorithm and in a fruitful manner, you have to ascertain where can the EEL, the external elastic lamina, be visualized in the whole circumference or not. If it is visualized, then either it can be a normal artery, or can be a fibrous plaque. If it is most often in Indian scenario and the lesions, you don't see there is a signal drop. So you have to see where is the signal drop, whether signal drop is in the lumen or in the wall. So if it is in the lumen, then you have to see whether it is a highly attenuated lesion, or which could be red thrombus, or low attenuated, which could be white thrombus. If it is in the wall, then it could be a high attenuation lesion, could be lipid, and low attenuation lesion could be calcium. That's how you differentiate the various morphologies. So you can see this is a normal looking artery with fibrous plaques. You can see all the layers all around. Then coming to you can see the light attenuating distally. So this is a fibrolipidic plaque, and here you can see a calcific plaque. So that's how, and this is a lesion which is protruding into the lumen, and with a high attenuation, this is a red thrombus, and this is a white thrombus. So based on these, what is the importance of morphology guidelines? The morphology guidelines is you can differentiate between lipidic, fibrotic, and calcific, and then decide your PCI strategy, whether you will do an upfront direct stenting, or use a compliant versus or a non-compliant, or an atherectomy strategy. So that is why the morphology is very, very important. That was the M component of the pre-PCI or MLD Max. Then coming to length, because stent has 2 dimensions, length and diameter. So you have to see the length, how long the length is. So for that, you need to define the reference segments. And the reference segments, there are 2 reference segments: the distal reference segment and the proximal reference segment. It's the distal reference segment from where you have to decide the size of the stent. So between proximal and distal reference segments, you arrive at a length. So you just have to scroll to the distal reference, see where is the healthiest possible zone, and then come to the proximal reference zone, and in between you will arrive at a lesion length, and you can correspond to the next available commercially available stent length. So this is the L part. Now coming to the diameter part. Diameter you can assess either by lumen profile, lumen diameter, or by EL to EL. If EL is visible, this is the standard. And then if the EL is not visible, then you can take the lumen profile, and lumen profile you have to upsize with the next available stent. In the EL, you have to downsize with the next available stent size. So this is how we do it. In our, we found that the distal reference was mean diameter was 3. So we took a 3 millimeters diameter stent, and the length was 33 millimeter. So now coming to the post-PCI strategy. In the post-PCI strategy, you have to have max. So the most important component is whether you have had a dissection or not. This is the most dreaded thing. So you have to see whether there is a dissection in the proximal or distal stent edges or not. Not all dissections needs to be stented or stacked up. Only dissections which are severe enough to acquire more than one quadrant arc or medial in dissection, involving the media, and if there are distal stent edge, then these are the dissections which needs to be tagged up. Not all dissections needs to be tagged up. This is a very important takeaway. Then coming to the apposition, for this computer of OCT gives us a position indicator by this white line. If there is a red line, means the stent struts are more than 300 microns away from the intima. So these are the apposition, malapposition, which should be tagged up by a semi-compliant balloon at a low pressures. Then the most important aspect is the expansion. It's all in the diameter. It's all the size. The larger the size, lower are the means. So here also this OCT computer basically calculates the expansion, and the expansion should be acceptable is if it is more than 80% of the minimum stent area, but the optimal and the lumen flow criteria are if the MSA is more than 90% of the mean reference lumen area. So that is how we calculate the MSA. And this OCT, the important part of the OCT is within 3 seconds of sweep, the machine itself gives us a good expansion. And we don't have to calculate the expansion as we have to do in IVUS. So this is the importance of OCT. It gives automated measurements. So, to further help us, now the new AptiView software also divides the stent length into two and then gives us the average of actual expansion limits. More than 90% is the optimal level. So, ladies and gentlemen, these are the two strategies which you have to keep in mind in order to complete your workflow. Just putting an OCT catheter and doing it does not mean. You have to basically give a structure to your workflow. And this MLD Max is a very, very simplified strategy. It's basically a checklist. Let me illustrate with an actual case which I did only yesterday. You can see that this was ostial LAD. Now, with only angiography, it was difficult to ascertain the stent size, whether you will do a crossover or not. So what I did was I did a OCT and found the MLD, the morphology of the plaque. You can see this is a fibrofatty. So, and the distal reference was about 4 millimeters and the proximal was about 4.5. So I used a 4 millimeter stent and a length of about 28 millimeter and then expanded it. And I used, because it was a fibrous lesion, I didn't use, I didn't pre-dilate, there was no calcification, and I did a direct stenting, and then post-dilated with the help of an OCT to arrive at a very good, this is my final picture. So Dr. Bhandari, I have finished, time is up, it's 000. I basically kept up my words, though I rushed, but I completed in time. Thank you.
Yeah. Thank you, Nishit. You were dot on time. Thank you for a wonderful talk. We'll have the discussion at the end. So can I invite the next speaker, which is Dr. Pratap, for his talk on zero contrast PCI with IVUS. So we all know Dr. Pratap, who's doing a wonderful work. And is from Kerala, Kollam. And we look forward to hearing his views on zero contrast PCI and how to do that.
Respected Chairperson, actually, I just, at the outset, I should thank Dr. Mohit and the Delhi CSI for inviting me for this topic. It's a zero contrast PCI actually. Why the contrast-induced acute kidney injury? An increase in the creatinine by 0.3 milligram per deciliter within 48 hours of contrast exposure, or increased to more than 50% within 7 days is contrast-induced nephropathy. Definitely, it is a third most common cause of AKI in patients. You should understand that AKI is more likely to occur after intracoronary injection than with intravenous injection. AKI after PCI is actually 0.3% of the patients go for dialysis as the data tells. But after PCI, it goes up to 3.3% with acute renal failure. And you have a higher mortality with the patients going for an AKI in the long term. In the case of an acute MI, you should actually understand that the higher mortality happens in these patients. So the actual impact of the AKI is actually increased hospital stay, irreversible kidney injury, need for dialysis, and death. Basically, the death of the contrast, you should understand that death also goes along with the what is actually it is 5 times in first year and 6th year, that is 2.8 times. How do you prevent this AKI? That is, prevention is the key. You have some data with the soda bicarb, drugs, and ascorbic acid. Actually, there is no clear benefits with any of these agents. What is actually prevents? Only 2 things. One is hydration and the low dose of contrast. Reduce the contrast volume is the key of reducing the contrast-induced damage. How do you do ultra low contrast imaging? That is actually your contrast volume should be less than eGFR. That is called ultra low contrast imaging. Even with that, there was a study published by Siad Ali and et al. Showing ultra low contrast imaging. They have shown that there is zero death in these patients. But from ultra low contrast, I am trying to produce a data with zero contrast. We actually create an indication of zero contrast by doing eGFR less than 30 with the serum, or the serum creatinine is more than 1.5 or eGFR less than 45 in patients with more than 75 years. LV ejection fraction is less than 50% in a diabetic population, MI, or anemia. We have done 33 patients. I'm showing the data of 22 patients where the diabetic population was 81% and LV ejection fraction is 43%. And creatinine was 2.7 plus or minus 0.4. eGFR was 30. And the risk actually, we have a complex subset with LM to LAD was 8 patients, LM bifurcation was 3 patients, ROTA we used in 3 patients. The known culprit STEMI patient was 3 in the group, and the ejection fraction was less than 50% in most of the patients. We used a femoral catheter in 93% of the patients, and number of wires we used was 2.5 plus or minus 9. Number of IVs run was 3, and the calcium, there was actually ROTA cases were there in our group, and we have syntax score was more than 23 in most of the cases, and even CTO have done in 5% of the patients. None of the patients had a complication in this group. So the mean follow-up of 90 days, and patients are all stable without any going for any dialysis. This is actually the steps I am just telling. Vascular access, femoral is we preferred. Preservation, actually the patient multiple guide wires requires. Catheter engagement is very important. The confirmed engagement there are 2 methods. One is saline injection method or an angiogram by roadmap. Wiring the vessels to create a loop in the vessel is very important. Wire inside the branches along with the main vessel, create a metallic solute or use a side branch as the marker. See, actually this is a way we do actually IVUS, CAG image to keep in the monitor for reference, same projection to be taken, calcification to be looked for reference. We actually the same fluoroscopic image, this is called metallic solute. We actually create, you can understand that there are multiple wires without even putting a single dose of contrast. Pre-IVUS to be done, what we will look for the IVUS is actually the reference diameter, length, and MLA. And we have to prepare the lesion very well. Pre-dilatation is a must. Rotational atherectomy for calcified lesions. And if it is actually repeat IVUS to be done after that, again the lesion preparation to look for dissection. Then the stenting to be done where the 3 things, one is a marker wire technique, metallic solute, as well as cine during the IVUS runs. And we have to do a post-IVUS to look for under expansion, malapposition, edge dissection. And a complication identification is important. Suspect the complication if the patient have new symptoms, new ECG finding, a BP drop. And serial echocardiogram to be important because you have to look for distal wire perforation because the patient actually does not have any contrast. I will show you one case, and if the time permits, I'll go to the second case. and a 72-year-old man with an acute on chronic kidney disease on dialysis for the last 3 weeks, admitted elsewhere for an angiogram, not done because of the risk of permanent dialysis, because the patient's creatinine was actually 4.53. And the Syndax score was 41, Syndax 2 was 47.1. So the admission creatinine was 3.69 to the hospital, and the dialysis chance was 3.65 by the BMC score, a Renogard score was 12.6, and the death chance was 33%. This is the angiogram done. Because this is an angiogram done, we are actually trying to do this. Actually, there are 3 shots taken outside. The patient came to us. This is actually, we use a 7 French EBU catheter. You should understand the wire is passed by keeping the angiofilm on one side. And we are actually putting the wire into the side branch. Everything is kept. The filter FC, we put 3 wires, 1 wire in the distal circumflex, 2nd wire to the upper branch of OM, and the 3rd wire to the lower branch of OM. What we did is actually we did an IVUS to the OM2. You can understand that we have seen the proximal vessel is calcified. A distal LMCA is looked. Actually, we saw the proximal tight calcified disease. Circumflex as to the OM branch was 1.8. Distal circumflex reference was 2.7. So we understood that this patient can have a 2.5 millimeter balloon. A 2 millimeter balloon taken to the OM, and we took a 2.5 into 30 stent OM2. We actually kept the stent inflated. What we see actually the proximal post-stenting MSA we have looked into, it was not fully dilated, but we have taken the wire, 1 wire out, keeping 1 wire in the circumflex. A pre-dilatation was done in the 2 into the circumflex, LAD. We did an IVUS. What IVUS showed is a different picture. A 360-degree calcium in the LAD, and the proximal diameter was 3.4, and ostial LAD was only 2.3, and POC was 5.4. And we actually took a balloon 2.7 because I wanted to remove the wire and do a rotor there. So actually I did a balloon dilatation in the circumflex part, 2.75 into 12 millimeter balloon. Stent boost was with the help of the stent boost. Then the distal circumflex area was 3.9, and we got a proximal circumflex is 4.3. We removed the wire. We actually wire is exchanged from the LAD wire to rotor wire by a balloon trap technique. We did a 1.5 rotor with 180,000 RPM. Exchange the rotor wire to the filter FC. We can see a pre-dilatation with a 2.5, 2.775, and we used a flex term of 2.75 into 10 flex term. It's well opened up. We used a 3-in-8 traveler balloon. Finally, what we got is actually, we got an excellent result there. LMCA to LAD, we understood it is actually a 4 into 26 millimeter onyx we used, and 3 into 26 for the proximal LAD. We kept a wire into the circumflex, and we actually put the second stent by keeping the fluorostor. And you can understand that actually stent boost with this head stent boost, we took a 5 into 8 millimeter balloon in the NC, and 3.5 into 12 millimeter Maverick balloon. We did a final IVUS, that is actually 6 IVUS run. We got LMCA is actually 12.2, POC is 9.8, and LAD was 6.5, and middle LAD MSA was 5.6. And there was no shift to circumflex ostium. This was the final result. We did not do any check angio after that, and patient was doing very well, and even now. This is another patient with the highest Syndax score. This was angiogram. I'll just run through very fast. I've left only 1 minute left out. This is a wire actually passing into the, just keep the wire. A circus actually a CTO. We put a wire, 1 wire into this, 1 branch, another wire. We kept 1 branch into the sinus nodal artery. IVUS to the circumflex. We used a 1.5 into 10 millimeter. We saw there is a 3 millimeter proximal vessel dilatation. I'll just rush through. We dilated. We found out what is the area. This is actually a 22 millimeter lesion length, 3 millimeter proximal, and there is a 2.75 millimeter vessel, 2.6 millimeter vessel. We saw in the distal vessel, it is 8 millimeters. So we calculated 22 plus 8 plus 2, that is 32 millimeters. We used a 28 millimeter stent. Just after the branch, we put the wire, 2.75 into 28 stent, 3 millimeter proximal vessel. We post-dilated. Then we took the wire out, 1 wire out. We went into the repeat IVUS is done, and we took a 3 into 15 NC Trek balloon. I'll just finish in half a minute. 3.5 in And finally, what we did is actually we did an IVUS. We got an excellent result there. And we went into the next branch, that is a ramus. What we did is actually we saw the proximal vessel is 2.75. Our IVUS catheter did not cross. A balloon dilatation was done. The vessel length was 330. With the 2 marker wire, we put a 30 millimeter stent, 3 into 12. Then this is actually the LED. We have multiple branches. We put 1 wire into the diagonal and 1 wire into the septal artery. We understood the distal vessel is 2.7. This is extend up to the ostium. We have kept 1 more wire into the septal artery, and the proximal dilatation was done. We did an IVUS again. We understood the ostial LED is 4 millimeter. The ostial LED to diagonal is 4 millimeter. Distal up to this 24 millimeters. We put a stent as 4 into 15 there, and we have seen the multiple wires. Finally, I've taken the second stent, removing the diagonal wire 3 into 28. Removed the septal wire also. Post dilatation was done, 3 into 12, and post dilatation was done. Well expanded stent. This is actually the final result. So actually I have done 33 cases now so far, and every patient is doing very well, and none of the patients went for dialysis. Thank you very much, sir.
Thank you. Dr. Mantri cannot hold the next talk, so we will be having 10 minutes extra because he had to go for some urgent work. So we have the last talk on HD IVUS by Dr. Arun Mohanty, and that will give us enough time for discussion at the end.
Yeah. Can you see my slides?
Yeah, if you can see.
Yeah. So good morning, and CSI branch for giving me an opportunity. And this is SD IVUS. Just doing an IVUS is not enough. We know this is the ultimate trial data which we saw. Doing just IVUS for the sake of imaging is not giving you good result. Optimal IVUS with optimal target-oriented IVUS versus a suboptimal IVUS guided PCI. The target vessel failure at 12 months are significantly different, and this is a recent data ultimate trial. So how you get an optimal result using IVUS? We need a novel IVUS system that has better image quality, better interpretation, better length, better measurements of lumen. So the image quality we know depends on different physiological physics like transducer shape, pulse length, and frequency, and whatnot. So image quality depends on temporal resolution, contrast resolution, axial resolution, lateral resolution. These are different components of the image quality that gives you a complete view of a vessel in IVUS. As we know, you go lower on frequency, you see deeper tissues. So the penetration of the IVUS is better with a lower frequency. That's why the peripheral IVUS have very low frequency. You tend to see bigger vessels, bigger depth, and larger depth. Once you go higher on frequency, your penetration and depth of the view is limited. You see the vessel wall and the luminal structure much better. Your resolution goes on very high, and penetration and axial resolution goes down. So we have a development of IVUS catheter over 20-25 years. We started with a 20 megahertz catheter. Now we have reached to 60 megahertz catheter by Opticross, Boston Scientific. And there are different companies making up to 50 megahertz. Some have multi-frequency catheter also. And the wonderful thing about this, with higher frequency, you have a lesser diameter of the catheter, is more trackable and more user-friendly. You can, in a 40 megahertz, you see this kind of picture, you see a better penetration. At 40 megahertz Opticross, there was a better resolution. Now with 60 megahertz, high definition catheter, you see the vessel wall, the stent stud, the position so beautifully, but the penetration is not much compromised. Like OCT, you have a very limited penetration, tissue penetration. In IVUS, you need a better penetration. So this penetration is the best bargain between the luminal profile as well as the tissue penetration. Look at the image quality. You see the OCT on the right side on the IVUS, exactly identical picture with all 3 layers you can see, but you see better depth, which you can't see in the OCT. Now, This is a 40 megahertz versus 60 megahertz. Look at the picture quality. The axial resolution as well as the lateral resolution is very well maintained. There is no compromise with the clarity of view with a catheter. So now the advantage of SD-IVUS is you can see bigger vessels. This is a Swan model carotid artery. You can see so beautifully all throughout 360-degree vessel you can visualize. And you see the stent apposition and malapposition. This is a OCT picture. You can see so micromillimeter differences of malapposition or well-apposed stent very well. And this is a 40 megahertz versus 60 megahertz catheter. This is one of my case. Nothing great about the case. This is a focal stenosis. We have stented. Now I have done 3 modalities: one OCT, SD-IVUS, and 40 megahertz IVUS in all 3. One can see the vessels. Just like OCT, you can see every 3 layers with the branch vessels, the tissues, deep tissues, everything. You can see the pericardium. And this 360-degree, like we see EEL, we give a lot of importance in OCT. In IVUS, you can clearly see EL in a plaque vessel also. If the patient, the vessel has atherosclerotic blood burden also, and also you can see the EL, which you cannot see in OCT many times. And the calcium load, you see there is a Hursu type of calcium here. One can see the calcium so beautifully in IVUS, and this is 40 megahertz. And this is a dissection, medial dissection. One can see this dissection flap so clearly, but in 40 megahertz, this little bit obscured finding. And coming to the large vessel sizing, tell me the size of this vessel in OCT. You will fail to measure this vessel if it is a left main or a proximal LED or a large proximal RCA. You cannot tell about the size, but in a large vessel like this in left main also, SD-IVUS gives you a precise measurement of dimension, so you plan your procedure very tactfully. Now coming to the thrombus, you see beautiful pictures in OCT regarding thrombus type, red thrombus, white thrombus, but thrombus is always a presumptive finding in IVUS. There is a limitation to that. And whether it's a 40 megahertz or 60 megahertz, you just see better thrombus visualization, but the red thrombus, white thrombus cannot be made by IVUS. This is a medial dissection. Here, the same vessel with some microvessels here. There's a side branch, here is a side branch. These are the microvessels with beautifully seen the same IVUS pattern like OCT. This is a new ISR with neoatherosclerosis. One can see there is a vessel here. Similar thing you can see here also. And there is a 360-degree intrastent neoatherosclerotic calcium. One can see here, but beyond calcium, there is a limitation of IVUS. No IVUS, whether it's high definition or 40 megahertz, you cannot see beyond calcium. The depth is a limitation. Now coming to plaque rupture, you always see beautifully in OCT, plaque rupture in SD-IVUS also. If it's a minor plaque rupture, you may miss it. It's a limitation of SD-IVUS. Now coming to stent apposition, you can see beautifully apposed stent in OCT, the stent expansion by a computer model, you can get 90%, 80%, but you don't know whether it is opposed to the EL perfectly or it is under expanded now also. But IVUS gives you a complete picture of whether the stent is fully expanded or not, and same time it gives you idea about apposition also. Now this is a malapposed strut. You can see the similar segment here in the same vessel. One can see there is a calcium chunk here, there is a calcium chunk here. And ISR, as I told, you can see this is an ISR with a calcific part here. There is a calcium intrastent. There is an intramural hematoma. One can see the intramural hematoma here in OCT. One can see beautifully double lumen with the intramural hematoma with SD-IVUS. Now coming to OCT and IVUS, you can see this is a large vessel. Tell me the size of this vessel if it is a left main. There's a major limitation. Most of the time in a diffuse disease vessel, you miss to calculate the vessel diameter, and this is a guesswork totally. And in a SD-IVUS, you can see beautifully in the same vessel, branch vessel like this. You can measure the vessel. You can see these branches like this, and there is calcium here. There is a calcium here. You can see everything now and then. Now coming to muscle bridge. Muscle bridges are very important to be identified while stenting procedure. This dynamicity of the vessel you cannot see. Most often you will not see in OCT, because OCT is a very faster pull back, 20 milliseconds per 20 millimeter per second. It is a 0.5 to 1 millimeter per second. So you tend to, if it's not a large muscle bridge, you will miss it in OCT. But in IVUS, you can see this dynamicity and you can avoid these segments during stenting, one can very well see the muscle brace to prevent further events. Now look into the pericardium. Pericardial space. No OCT will give you this kind of pericardial space, and you know this is a very thin wall. This is a LED, mid LED. This is free. Just imagine if you have a calcium here and your balloon is an oversized balloon, then this area is going to rupture here. This is the potential space for your pericardial artery rupture and pericardial effusion. So if you identify such things beautifully, you can see in SD-IVUS, and you can prevent these complications. If you have a calcified lesion, you be careful, you will rupture the vessel here. This is a patient in our lab. Look, there is a very, after post-stent, there is a very minor haziness here. One can see there is a haziness. What is that? In a SES setting, when it's a thrombus, it's a dissection. What is that? So we did an OCT. OCT showed us beautiful middle dissection. Same patient, I've done an IVUS. You see the beautifully seen middle dissection also. Now, there are catheter development in different companies. This is a Silicon Valley medical equipment devices. They are getting multi-frequency operations. One catheter you can have 40 megahertz, with one catheter you can have, same catheter you can have a 60 megahertz picture. Depending on a requirement, you can change the frequency. These are the development. Now coming to the lesion assessment, the QCA, IVUS, OCT, and QCA, what are the vessel diameter? We know from our studies, with a conventional IVUS, it overestimates the vessels, QCA underestimates, and OCT is equal. In a phantom model, OCT is equivalent and IVUS overestimates. But there is a small study of 12 patients. This is the data. One can see with SD-IVUS, it correlates with OCT dimension exactly like OCT dimension, linear correlation with SD-IVUS. So SD-IVUS, whatever you measure, this is the exact size of the vessel like OCT. Now coming to the MLD max, what Dr. Nishit discussed, with the MLD max, which is a very hype thing, we were doing this thing routinely in our practice. And morphology, you can see better morphology in IVUS, SD-IVUS. You know the vessel size. Again, a limitation of the vessel size is here. We know the vessel is fibrotic here. There's a lipid pool one can see here clearly, but there is a ISR 360 calcium. One morphology you can see length in the same patient we have calculated with OCT. This is 30, 31 in IVUS. And about the diameter, tell me the diameter again in this vessel. Here, where in SD-IVUS, precisely you can measure the dimensions. Now coming to the apposition, again this issues of apposition. This is apposition excellent with OCT with a computerized model, but look at apposition is good and expansion same time you can tell precisely. Now this is a bar we usually get, but this kind of picture at the MSS side and different section, I agree there is no automatic data you get on IVUS, but you can analyze the whole vessel within 2 minutes. Now coming to the residual plaque burden, which is a very important factor for subsequent ISR and failure of the stent. If you don't have a 360 degree, more than 220 degree of EL, you cannot tell about plaque burden in OCT. And majority time, you don't see this kind of EL in a disease vessel. In a IVUS, it takes 30 seconds to calculate your automatic plaque burden. If you have plaque burden of more than 50% at the stent edge, you avoid that area for a geographic miss, which is precisely diagnosed by SD-IVUS. Getting this picture in SES, this is the limitation of SD-IVUS. You cannot tell about red thrombus, white thrombus, and these macrophage reactions and cholesterol crystal plaque rupture. This is the limitation of SD-IVUS. For SES, definitely OCT has a better edge. So my take-home message is intracoronary imaging is very useful in PCI optimization, and OCT-IVUS are complementary to each other. SD-IVUS has the best combination of high resolution with a good axial resolution for deep tissue imaging, very useful for vessel sizing, accurate like OCT, and length assessment for and plaque morphology analysis, calcium depth, and SES assessment of interluminal plaque rupture, macrophage, and then cholesterol crystals. This is the limitation of IVUS, and calcium depth is the major limitation. Thank you for your kind attention.
Thank you, Dr. Mohanty, for the wonderful talk. We have about 10 minutes, so we can take 3-4 questions. And I think my co-chair Ripin is there, and I don't see Jamal. If there are other co-chairs, they can pitch in, or if there are other, I can see Rajesh now. Rajesh joined recently. So if there are any comments from, or do we have a chat questions which the organizers have?
So Dr. Dhal is there online? Dr. Dhal.
Yeah, he's come
Hi,
back.
Dr. Dhal, morning.
Morning.
So are we entering into the era from, say, angiographic PCI to PCI optimization with the intravascular imaging, and now the precision PCI, where you are talking about imaging as well as functional assessment for like putting the stent?
Yes and no. The reason I'm saying no is because this is going to lead to incremental costs. It's going to add to the burden of PCI. But if we want to do physiologically guided and we want to compete with the surgeons for having great long-term results for our patients, then the answer will be yes. Especially in diffuse disease. Because I think a big challenge in our country is when you encounter patients with a diffusely diseased vessel, and we end up either putting full metal jackets or long stent lengths, which would actually compromise the patient's short, medium, and long-term results. But by using IFR and precision PCI, we can be judicious, and imaging, we can be judicious. One of the most important things about imaging is that it will help us not to oversize our stents or balloons. So I think all this will lead to better outcomes, less complications, and we should incorporate it into our practice. The MLD Max is a great beginning about having a systematic system by which you can have a technique by which everything is like a process, a shop floor. But the same thing can be incorporated if more and more labs have IFR integration with PCI, then and can have what is automatic co-registration. We should be able to perform much better. The future is going to be, if this is going to be combined with CT data, we are going to have image-based FFR or IFR, which is going to be even better. That once you do take a patient, you know exactly what you have to do. But we are in the contemporary practice, we are still not there yet. Maybe a few years, and we'll be there.
Very nice, thank you.
My question is to Dr. Nishit and Dr. Arun Mohanty. Let's say we have cost constraints and a lab has to choose between a HD IVUS and OCT. Which would he go for as of now? With all that?
Let me answer that. This is a very difficult question actually. If you use both devices, if you have both systems in your lab, your preferences are different actually. Then you try to choose in case-based scenario. You want to do an IVUS where you want to see a ostial lesion, left main lesion, and if there is an SCS, I'll definitely go for OCT if it is not an ostial lesion. And large thrombus burden with the TIMI3, TIMI1, TIMI2 flow, then OCT is useless, in SCS also. So your indications for these systems, but these are complementary to each other. One system is never enough, but if one lab has a cost constraint, I'd go with an IVUS system rather than an OCT, because OCT has many limitations. You tell me in SCS, if you identify a macrophage or a cholesterol crystal or a plaque rupture, how it gives you any extra advantage, except for the plaque rupture, which is acute and very devastating plaque rupture, then only you stent it. Otherwise, a chronic plaque rupture doesn't warrant a stent also. So this type of fancy thing, whether I get a red thrombus or white thrombus, my management is not going to change. So in that case, I'll definitely go with an IVUS rather than OCT if I wish to buy a single system for my lab.
Any comments, Dr. Nishit? Dr. Nishit is here. He's already left.
Dr. Bijay Varghia, your comments, sir, on this?
Dr. Arun, yes, you have rightly mentioned every operator should be acquainted with both the IVUS and also the OCT, and then there are certain lesions where one can have a preference of IVUS over the OCT and vice versa. Regarding, say, you have mentioned about the calcified lesion, I feel that, okay, calcified lesion is the one where you can have an idea about the depth of the calcification, exact plaque modification with the OCT, which to certain extent is a limitation with the IVUS. Again, the stent optimization, which somewhat is difficult to identify when the calcium versus struct opacification is there in the IVUS, which can be very well clearly visualized in the OCT. So that's the advantage in certain area where the OCT is at the upper level compared to IVUS, and LAPMIN and the large vessel are the one where the IVUS is preferable over the OCT.
Thanks. I just want to pitch in and ask Dr. Pratap, then when do you aim for a zero contrast? It's not always zero, it's minimum. So are you guided?
It is always zero, sir. It is actually the cases which I have done is absolute zero, sir.
More often than not, it is minimal contrast where
Actually,
you.
there are studies done
Yeah.
by people with a low contrast or ultra low contrast. Ultra low
Yeah.
contrast is less than less than the contrast volume of eGFR.
Yeah.
And actually, if a low contrast is actually less than 3 times the eGFR. But I used all these cases, the 33 cases where I have failure of 2 patients. I'm just telling 2 failure means where I have to use some contrast to understand when the patient had a ECG variation as well as chest pain. I just checked it. Other cases, I did not even do a single drop of contrast in these cases, where only the angiogram images allowed me to do the cases.
Okay, so angiogram from before, and
Before.
then you wired them without a contrast.
Without a
and
single.
used an
Actually,
IVUS.
this is angiogram taken from outside, the patient coming with the CD, then you have to keep a computer near to you, and then the similar picture, similar angle, similar projection, you have to wire the system. And always you should be careful that the wire goes and identify with an IVUS to identify we are in the lumen itself. And you should always keep a loop in the distal vessel, distal part, otherwise you may perforate and go. And don't use the wires which can perforate.
Dr. Pratap, so medico-legally, are we okay if we don't take a final shot after the angioplasty?
Actually, only for the insurance purpose you can. Otherwise, actually, this is the same discussion came with the Gary Means. Actually, he was telling which angiogram can give you a better result than an IVUS picture in distal vessel. And only situation the TIMI-3 flow cannot be identified. That is the only point where the patient have no symptoms and all these things. Actually, none of these patients went for any dialysis, and I have done angioplasty even for the patient with a 6.5 creatinine, and none of these patients went for. Actually, this tool to be utilized by the people who are well versed with the imaging, and people should have a good training of IVUS. And basically, you can use a saline OCT. That is one way of doing with OCT. But that actually I keep a reservation only for the patient with a severe LV dysfunction. You cannot use that. Otherwise, with the LV is normal lesions only you can use. I have published one case report in the Indian Heart Journal. Another case is already reported. And this one case I have done as LMCA bifurcation with a rotablation. And that was the first reported case in the world.
Pratap, your expertise is unmatchable, but then any message to the fellows who are attending the meeting that what are the 2 or 3 cine, which is very important during the PCI, should be taken just to consider, say, ultra low contrast PCI instead of going ahead for, say, zero contrast, which you are practicing?
It is a wonderful question. I will tell you that if you go to the left injection, you should take an RAO caudal projection for an AP cranial or an RAO cranial projection. If you are not clear about the ostium of the LMCA, you can have an LAO caudal. Only maximum 3 projection for left system, and right system, I will tell you only 1 projection, that should be LAO cranial projection.
And as Dr. Amita was asking about, need to have a final angiogram to look for TIMI flow, and also to rule out, say, possible perforation, which is sometimes.
Rajesh, whenever you do a zero contrast, you should have a echo machine inside the cath lab, and you should always do, whenever there is a doubt, you should do, and we do an echocardiogram during the procedure, after the procedure, after 6 hours also. There are wire perforation can cause tamponade only by 5 to 6 hours, which we have experienced in life.
Very Nice teaching point. Pratap, any comment about, say, radiation dose, with, say, you are so comfortable giving a dye during the PCI and then vis-a-vis no dye and only on the cine or fluoroscopy, any amount of radiation dose which is different between the two modality?
Rajesh, actually, I usually do a fluoroscore in these cases. I don't do cine at all. That is the most important thing. And you have to do a lot of more fluoro than a normal angioplasty. So you have to avoid the cine in these projections. Take a fluoroscore in all the cases, and I have done only fluoroscore in these cases. I don't do a cine in this case. That's very, very important.
Very nice.
I think the organizers would want us to move on to the next session. If there's any one last question or comment, we can take that.
Dr. Pratap, any difference between zero contrast or ultra low contrast as far as outcomes are concerned? Like ultra low means like we are very concerned like a final shot. So if we take a 5 ml dye final shot and versus what you are doing as zero contrast.
I will tell you, basically you should understand that even in ultra low contrast, 1 drop of contrast it will be damaging the kidney, no doubt about it. I actually do, even these patients come with a high creatinine, we take a 10 ml of contrast and take these 4 injections with 10 ml saline added and make it 20 ml and take an injection. Always we should be careful that you should cannulate properly and take an injection, which you will see, and no panning should be done because it is very, very important for multiple injection to be avoided. And I personally feel that ultra low contrast is definitely a choice if you cannot do a zero contrast, but if you can do absolute zero, that is the best for the patient and it is optimal. But always like 80 MLD max, you tell 80% is better, 90% is optimal. Like this ultra low contrast is definitely not a bad choice, and the studies are already published only with ultra low contrast.
Thank you.
Thank you. Thank you for a wonderful session. All the speakers and the interaction has been wonderful. So we can hand over to the organizers for the next session, please.
Thank you so much, sir. Now over to Dr. Amitabh sir to introduce the chairperson and speaker for the next session. Thank you, sir.
Thank you. Thank you. So the next topic or the next session is on cath lab nightmares, and this is often the most attended sessions in any of the conference, and we don't live long enough to do all the mistakes and learn from them. So we should learn from others. I would not say mistakes, but from others' experience. And for that, we have a very distinguished expert panel of none other than Dr. Vijay Trehan, who I believe is the Superman of complication management, Dr. Sabal Mukhopadhyay, Dr. Praveer Agrawal, and Dr. Subrat Lahiri, Dr. Viveka Kumar, and Dr. Vivek Gupta. So welcome to you all. And let's start with our first talk, where how I manage allergy perforation by Dr. Prashant Pandey.
Yeah, good morning, sir. Am I audible, sir?
Yes, you are.
So the case for today's discussion is a 65-year-old female. She was a diabetic
Dr.
for 5.
Prashant, we cannot see your slides. Have you shared your slides? Yeah.
So are my slides visible, sir?
Yes, they are.
So my case is a 65-year-old female. She was diabetic for 5 years and hypertensive for 10 years. She presented with angina on exertion for last 1 year. TMT was done outside, which was strongly positive for inducible ischemia. Her echo revealed normal LV function. The angiogram was done outside, which reveals proximal CTO of the LAD. RCA and LCX had insignificant disease. So we planned a PCI for LAD CTO in view of strongly positive TMT and persisting symptoms on OMT. So a right femoral approach was used and a 7 French XB3 guiding was used. So this was the initial angiogram which we took, in which we can see that there is a proximal LAD is chronically occluded, and there is a antegrade filling till mid LAD. And this is a long segment occlusion. LCX had insignificant disease. So this was the second angiogram, in which we can see that there is a occlusion of more than 20 millimeter, and there is a antegrade filling from the collaterals from the LCX. So our initial approach was antegrade approach. So first of all, we used a Fielder XTA wire with a microcatheter. And this wire was, microcatheter was used, but this wire was going into the false lumen. So this wire was redirected, and we could reach the diagonal branch with the help of microcatheter. After this, we used a parallel wire technique using a Gaia 2 wire, and with the help of Gaia 2 wire, we could reach the distal LED. After this, we dilated it with a 1.5 Tazuna and then 1.5 wire. This was the angiogram after dilatation with the 1 millimeter balloon. After the dilatation with 1.5 millimeter balloon, the wire was exchanged with the Xion blue wire, and it was dilated with a 220 non-compliant balloon. So this was the angiogram after dilatation with a 220 non-compliant balloon. After that, distal, we placed a 2.75 into 40 DES in the mid to distal LED, and 3 into 35 DES in the ostial to mid LED. Till now, everything was going fine. After that, we decided, this was the angiogram after stent dilatation, in which we can see the result was satisfactory. After that, we decided to post-dilate it with a 3.25 into 15 millimeter balloon in the proximal LED, and 3 into 15 mm balloon in the distal LED. After this, suddenly we noticed that patient had hemodynamic deterioration. There was tachycardia, there was hypotension, and we took a shot, and we can see there is a large LS5 perforation, and with this angiogram, we can see that probably the site of perforation was in the it was proximal to the distal stent. So the prolonged balloon inflation was used. Patient deteriorated quickly, so pericardiocentesis was started with autotransfusion, and patient deteriorated very quickly, so she required mechanical intubation and mechanical ventilation. After this, as the site of perforation was looking proximal to the distal edge of the stent, we placed a 2.8 into 18 millimeter graft master at the site of perforation, which was visibly looking as the site of perforation. But even after the placement of this stent, we had a persistent leaking into the pericardium. So a second graft master was deployed, which was deployed distal to the distal stent. After this, this was post dilated, and this was the final result after the implantation of the second graft master stent. So the challenges in this case was that through angiogram we were not able to localize the site of perforation, and we thought the site of perforation was probably proximal to the distal stent, but actually it was distal to the stent. So we had to use 2 graft master of the same size, and finding the second one of the same size was also a challenge because it was probably not there in the shell. Secondly, this could have been avoided if we have used imaging. We didn't use imaging in this case, so probably this was one of the disadvantage. And thirdly, because the patient deteriorated so quickly, I think every cath lab should have well-defined role of each person in case of such catastrophe occurs, that which person should, one person should be doing pericardiocentesis, one should be ready to do mechanical ventilation. So all these roles should be well-defined during these catastrophic cases. And secondly, more than one size of each graft master should be available in the cath lab, because most of the time one size is available, and if we require 2 stents of same size, then it is a challenge.
Thank you, Dr. Panda, for a very nice demonstration of management of LED perforation. So a few comments. One is like, in today's world, we should be as adept in cardiology procedures as presentation. So my suggestion to you would be, next time when you do a presentation, make sure that your videos are on loop, so you don't have to.
I made it in a loop, sir. It is not working on this.
Okay. So
yeah.
I'll let it. Secondly, your comment on the fact that multiple diameter graph should be available. Well, it is well taken, but one thing to remember, all these graphs ultimately have the same graph which is mounted on different size balloons. So in a catch situation, you can even use a different size diameter and then subsequently blow up with the appropriate size balloon. And I think that these two things. And thirdly, more importantly, whenever you overlap a stent graft, you should remember that almost 2 millimeters or 3 millimeters is uncovered. So you have to make sure that your overlapping of stents graft should be sufficient overlap. Otherwise, that covered portion will not overlap and it will still continue to have. And probably this was the reason why your first stent graft probably was not positioned in the right place. So I would invite Dr. Trehan to comment on the case and then any other.
As far as videos is concerned, I think a very simple suggestion is that even though the quality of the images may not be very good, but I think it is better to use GIF images. If you have any problem in running your loops, then you can convert your videos into GIF. If they are into GIF, it's a picture format. There is never a question of whether it will run or not. It will always run. And for a picture like in this case, I don't think it's so delicacy about the observation was required in this case.
Yes.
So if you put them into GIF, they will just run. Number one. Number two, I think Sir Donald Boehm, who is no more with us, he gave the concept of bigger the better. And that was in the era of BMS, because the stents used to restenoze too much, I think even up to the tune of 30 to 40%. Even though the Benny stent and stress showed it to be 20%, but they were in the ideal cases. And if you were using less than type A lesion, then the restenosis used to be very high. So they suggested bigger the better. But Gary Minch corrected it and said, go as big as possible, but don't perforate. So I think we should have a carry home message. And I think all of us, at least in retrospect, should understand that this LED, if at all, it was under in the very proximal area. The site where it perforated, even I think all of us could have accepted it to be acceptable, because that will not amount to more than 30% residual stenosis. And in the absence of imaging, I think we should understand that chronically occluded vessels have a tendency to have negative remodeling. So how do you perforate a vessel is a combination of bigger size and higher pressures. If you have a 5 millimeter balloon and you go up to half an atmosphere in a 2 millimeter vessel, it will not perforate. If you have a 5 millimeter artery and you take a 3 millimeter balloon and go to 100 atmospheric pressure, it will not perforate. It's a combination of higher pressures and bigger size. And I think the carry-on message should be that probably with this kind of a thing, if you try to make it better, then remember Gary Minch, that don't perforate. And the simplest and most important thing is have an imaging which can tell you how much is a vessel beyond this lumen. Number one. Number two is, once you perforate, I think everybody has discussed very elegantly in all the conferences that try and use so-called ping pong technique. And the advantage of ping pong technique is not that it gives you comfort, but let me tell you, very important thing is, if you use a ping pong technique, you have one balloon which was already there in use for the procedure, which you use for tamponade. Just use that balloon for localization. And how do you use that balloon for localization is, you keep moving your balloon millimeter by millimeter and keep giving small shots till you start observing a leak. The moment you start observing a leak with a balloon inflated, it tells you that your stent has to land 4 or 5 millimeter proximal to that proximal end of the balloon. That's how you can localize. There is no other good method of localization unless it's a small streak which is clearly getting out from one border of the vessel. Otherwise, a perforation which creates a tamponade which is like this, often it is not very easy to localize on angiogram with given the hemodynamics. And I think the take-home message should be best localization. Even if you have 10 covered stents at the shelf, it is a very sorry state of affair that you put one stent and you are still tamponade, you're still leaking. So I think, according to me, the carry-on message is try to localize with a ping pong technique in which the first balloon which was gone to block the perforation, just move it millimeter by millimeter, deflate, push it a millimeter, inflate. push it a millimeter, inflate, and then check with a contrast. The moment you find that your contrast is now trying to exit out of the vessel, that tells you that this is a site proximal and your stent should land proximal to that. And we know that 2 to 3 millimeter has to be anyway, which is uncovered, has to be there. So maybe a couple of millimeter more. So if you have the proximal end of the covered stent 4 or 5 millimeter proximal to that edge of the balloon, where you start seeing the perforation, I think that should be the real site. And that you can keep it as a reference at the time when you are deploying the covered stent with a ping pong technique. I think rest of the things were very well managed, and this message should go loud and clear that use that balloon to localize the site of perforation.
Yeah, a really very nice technique, and we do learn every time we see a complication. So the next is a series of complications by Dr. Rohit Modi, and how I manage my cath lab nightmares case series. Dr. Modi, please.
Good morning, everybody. My case series is also based on perforations in the cath lab, which we faced in our day-to-day practice. I think I am visible and audible.
Yeah.
Yeah. So the perforations we encounter in our practice can be divided into type 1, type 2, type 3, type 4, and type 5. In type 1 perforation, we have a guarded outcome, and we are guarded, and then we check the hemodynamic instability. If it is stable, we inflate the balloon at the perforation site and may come out. In type 2, the main step of type 2 coronary perforation is to inflate the balloon at the site of the perforation and assessment for the progression if it progresses to type 3. Then type 3 is the most dreaded, I would say, complication in the cath lab. And here the management hovers around how to put a covered stent together with Meyers to restore the hemodynamics instability of that patient, may require a pericardial drain insertion and restoration. Then type 4, if the perforation is in other cavity, it's a type of a more stable type of a type 3 perforation, I would say. Then in type 5, we get a distal perforation, generally when we are using hard wires, or a perforation from at the distal end of the vessel. So this is a type of a perforation we got in our cath lab, and there was a Twitter poll. 70-80% of the people said do a balloon tamponade and wait. Few advised cover stent. The important point I would like to emphasize here is to do serial echos even after we are sure that the perforation is not leaking. Make it a point to assess this patient's 6 to 8 hours or maybe overnight with serial echocardiograms. And for seeking for the perfection, as in this patient, we had not seen, we could have done an imaging before the ballooning it, and could have seen a calcium spur that could have helped or made us more cautious in this patient. And this is another type 3 perforation. Keep it calm and carry on. Again, I'll discuss the balloon tamponade, communicate with your team, pericardial drain, become a group and save analgesia for ischemia. If available, ask for a cell saver and locate the cover stents. So as described earlier, as discussed by Dr. Trehan also, the commonly technique used is ping pong technique, where we take another guiding catheter. We may take a 8F guiding for delivery of the proper delivery of the covered stent here. This is the ping pong technique, and a very important point already discussed by Dr. Trehan here. Here I go to my case one, a female 43 years old, came with non-Q anterior wall MI. She was diabetic, normotensive, dyslipidemic, body mass index of 26. Angiogram, you can see there was a tight lesion, LED, mid LED, but the vessels did not look very big in size. We wired the lesion. I don't know, I couldn't run the slides. In that, ultimately, when we stented the vessel, there was a type 3 perforation that occurred within the middle of the stent. And the patient, we just went up to 16 atmosphere of pressure. The patient collapsed and developed pericardial tamponade. We were doing a direct stenting here, and the patient collapsed. The LED was blocked with a inflated balloon. Immediate pericardiocentesis was done with a pigtail position in the. That day I was alone in the cath lab, so I couldn't do the tedious ping pong technique. I just blocked the LED. And then prepared the graft master. Immediate pericardiocentesis have to be done because the patient was unstable. A graft master was put across and inflated, and the perforation was sealed. So this is a comparison chart of the various covered stents: graft master, B graft, and papyrus. Papyrus is the most convenient covered stent, but probably not available in India. So this is how we put a covered stent through 6 French guiding catheter, or we may use a 7 French and 8 French guiding catheter. So another case, 67 years old, came with acute anterior wall MI, but the artery was flowing. You can see the distal LED, that is a small vessel. We balloon dilated. It was also calcified, small and calcified vessel. We balloon dilated, stented. We did a post dilatation of the stent, and there was a perforation. But that was a very calcified and small vessel distally. And the patient collapsed, developed pericardial tamponade immediately, as indicated by severe hypotension and sinus tachycardia. Immediate pericardiocentesis done with pigtail. Patient's vital improved, and then a stent graft 2.8 into 19 millimeters was inserted through the same 6 French guiding. This was the pericardiocentesis. Then the covered stent deployed. But what happened when we deployed the graft master? It just got stuck there. It was not fully expanding. We pulled the graft master, and the shaft of the balloon remained inside. So it closed the vessel that way. But we could restore the flow. We could restore the flow with the balloon of the graft master still there. And the perforation got sealed. So this was a complication where that helped the other complication. And there was a case 3 here. The 46 years old male came with acute breathlessness, LVF. We thought it was a troponin were raised, so we thought it was an acute case. But when we tried to do it, it happened to be a chronic total occlusion. We crossed it with a wire with BMW, which would not cross. So we took a Fielder XT. The Fielder XT we were able to cross it. And when we crossed it in the middle part, you can see there was in the middle part of it, there was a perforation. So we immediately we put a micro catheter did the serial echocardiogram. The patient was stable. We immediately LED balloon dilated, and the perforation was echo done show only mild pericardial effusion, and the patient was hemodynamically stable. Took another guiding cat 7F JL.
More minute, Dr. Modi.
Yeah, and took a micro catheter and fat embolized it, right? So this type of perforations can be sealed by the fat embolization. Finally, the bleeding stopped. Patient left like this in a CTO state. The echo we saw that LED area looked scarred and dead, so we did not do anything else to this patient. Another case,
Dr. Modi,
I'll just skip,
we might discuss the cases rather than adding to the cases. So I would like to ask about the second case, because the images were not very clear. So what exactly happened? We were not really understanding. You deployed the
I deployed the graph master, but it was because of the severe calcification there, it did not fully expand it. So I tried to pull out the balloon out of that partially deflated stent graft. So when I pulled my balloon, it got stuck. I pulled it with a force. What happened that the balloon remained at that side. My shaft came out and the balloon got broken from the shaft, and the balloon remained at that side and sealed the perforation.
Okay, so you had a balloon which ultimately was semi-inflated or probably not inflated.
It was inflated, but there was a lot of calcium. It was not getting properly.
Finally, finally you were able to deflate the balloon, but it was not coming out.
It was not coming out. I pushed it with a force. The shaft got broken.
Okay.
At the site of the junction of the balloon with the shaft, the balloon remained inside. The balloon remained inside.
Okay, so you were able to determine the point of breakage of the balloon.
That was just at the junction of the balloon to the shaft. Yeah.
Okay. And then subsequently, what you did, you let it remain there?
I let it remain there. Patient was very stable because patient was post MI. Even I didn't get the ST elevation in the ECG, and patient did not have any pain. Hemodynamically very stable.
Okay. So my take home with all these cases that you mentioned, especially the second one was obviously an MI, but the third one specifically, you ultimately did a echo and you found out that probably it was not required to do the stenting. And so what this thing is, we do all kinds of CTOs and we have been doing it. But at the end of the day, we should be very clear before we do the procedure, whether the procedure is indicated, because now we are justifying a perforation and not doing anything after the perforation by saying that we probably did not need it, but that should have been a decision that should have been taken before we ventured into a.
That is okay, but what I thought while taking that patient, I thought it was an acute MI because the patient had come with chest pain, and I did a trop eye also, so I thought it might be a acute MI with a clot. But I tried with a BMW and then was surprised to find that it was a CTO.
Yeah, I'm sure all of
us. Okay,
Amitav,
one point is there. Were you very much sure how much of your shaft was lying within the LED? I mean, it is
that I was sure because when I took out the shaft, it was at the junction of the balloon and the shaft. I have a follow-up of the patient also. The patient is still doing fine about 1.5 years after that thing happened.
I think Dr. Trehan will say, and often it tells us a story, and we had these problems where you must immediately see whether how much of the shaft is actually within, because that is radiolucent.
Yeah, we inspected the shaft.
Check it.
The whole of the shaft came out. The whole of the shaft.
Actually, the shaft usually elongates, so it's actually difficult to really find the site of break because it elongates. So Dr. Trehan is smiling. I am sure he has some comments.
Yeah, we had a case and we reported it, and sir will tell you how we do, and we have faced that problem later also. Sir will just tell you.
It's very, very. I really cannot conceive that you can have a transverse fracture of the shaft of the balloon right at the junction of the balloon with the shaft. It is nearly impossible because if your balloon got stuck, and you were muscling around with the shaft.
Stretched and it
You were
will
trying
break.
to pull it, and you had to apply an undue force. That invariably leads to stretching of the
Stretching and
balloon
breaking.
shaft. And if it stretches, then even if you think that you have received a long segment of the balloon shaft, it is still possible that still a long segment is left proximal to the balloon. And I think the first thing, whenever you break anything, is let it come out and let it be compared on shelf or on table with a new balloon, wire, or anything. That will tell you exactly what has happened to your system. Where did it break? So I think it would have been nice if you had shown the photographs of what came out. And as far as patient doing fine is concerned, it's okay. I mean, I'm not saying that if you leave a foreign body inside, then almost every time you'll have a problem. But I think it is better to understand as to what went wrong, and so that while we are presenting, we give a message that probably if I get into a trouble next time, then I will manage it like this, or I can prevent from getting into trouble like this. I think once you were having a problem in pulling out the shaft of the covered stand balloon, the first thing should have been, first of all, take a breath, think what you have to do. And the first thing which one should learn from these conferences is never muscle around, never pull anything with undue force. What is recommended by the company? And if you just pause for a second, that I don't have to apply force, then what should come to your mind is that there is a constrained environment. You are not able to fully inflate your stand graft since there was a calcium outside. And since you were not able to fully inflate, now if you deflate these covered stand balloons, they don't get back to their profile as is with a very compliant balloon. So they tend to become more flat, they tend to have wings, they tend to get stuck into the covered stand. And how do you free it? One simple technique is you pass a wire alongside this balloon, take another small balloon, and you inflate at that side. If you inflate at that side, that will help you in expanding the covered stand, because you're taking a smaller size balloon. Let's say you took a 3 millimeter covered stand. Now you can take a 2 or 2.5 millimeter balloon alongside the covered stand balloon, which is not deflating or which is not coming out. That will help you to slenderize the balloon which was not coming out. Number one. Number two is sometimes the contrast which is left in the balloon, that makes the balloon heavier. If you test on the table, if you have a balloon which is filled with contrast, now you deflate it, then you have a balloon which is filled with saline and deflated. You will find the profile of a balloon which is just blown up with saline and then deflated is much more malleable than is a balloon which has contrast in it. So second thing which can be done is you can dilute the contrast in your balloon which is not coming out. And how do you dilute it? Just connect a saline to it, push saline, pull it, push saline, pull it. And if you're doing it multiple times, what will happen is the quantum of contrast within the balloon which is failing to get out will reduce, and that's how it will make the balloon relatively supple. And you can facilitate it by slenderizing it by having a wire and a balloon alongside and inflating another balloon inside that stand, which will also help in expanding the stand and releasing the balloon. I think these things are relatively simple, which could have been done. The third case, I think you were very happy in just seeing that there is nothing and LED is fine. You should have taken a contralateral shoot, because CTO, if you perforate distally, I don't think you are entitled to say everything is fine by just taking shots from the left corner only. Because
the other side right was not filling actually. It was not, there was no flow from other side. I took it as an acute MI and took it for the case, but there was no retrograde filling at all.
But finally, once you did the case, you soon realized that this is not an acute MI, isn't it? So once you realize that it is not an acute MI, I think then at hindsight, at the end of the procedure, you should have gone back to the right corner, you have taken a shoot, because sometimes all of us, we can suspect that it is ACS, and sometimes we can find a surprise. It's not like an ACS looking hard lesion. So it is possible with everyone out of us. But if during the procedure you realize that this was behaving more like a CTO, then I think it is, for me, I think it will be better that before I get the patient out of the cath lab, I'll take the diagnostic catheter on the other side and take a shoot and be sure that I'm not leaking, because it will be very unpleasant surprise that you send the patient from here to the ICU and then 3 or 4 hours down the line, then the patient collects a fluid and then the patient is left to the mercy of a junior most person.
We need to move forward. I think the points are well taken. So the next presentation is by Dr. Gautam Swarup, dislodged stent in the left main. Dr. Gautam, please. Dr. Gautam, we can't hear you. Have you unmuted yourself?
Dr. Gautam, yeah, please.
I hope I am audible as well as visible to you.
Yeah.
Please go.
I have listened all the esteemed faculty over here, and it is very true that if you struggle with your hardware, somewhere, somehow, someday you will mess up with your case, and any case will be a battle for you as well as for your patient. So I have got a case recently that was an stent dislodgement in the left main coronary artery, and in the short period of time, whatever was in my mind, I did it, and I hope all the esteemed faculty will analyze it and suggested me the alternative and the better thing. So I am starting with that. So it was a 62-year male, 8 years diabetic, and since 10 years he was hypertensive, hypothyroid, smoker, as well as severe COPD. He was having nephropathy with the previous creatinine level was 1.6, presented with the angina since 3 years on anti-anginal somewhere outside, presented in the emergency with the acute onset chest pain. Troponin was borderline, but there was STT changes in the inferior leaves. Blood pressure was a little bit on the lower side. It was 116/78. Echo shows 48% ejection fraction. This is the angiography of that patient. If you try to analyze it, there is a disease in the ostial left main, and it was a kind of the trifurcation type of the lesion, or you can say quadrifurcation. Here I don't have a RCA shoot because somehow it is missing. There was an RCA which was disease, so I planned the plasty for RCA. It was a focal disease. I did angioplasty within a minute. The case was going on smooth at this point of time. Then again, I wanted to stent this portion of this left circumflex, which was a little bit tight at this portion. Probably I was wrong. I do not want, I didn't have to chase this, but I wanted to do so. So I took a EBU guide from the radial route and tried it to pre-dilate with a 2 into 12 millimeter balloon. Balloon goes smoothly. Nothing was suspicious and nothing was in my mind at that time because there is the balloon goes smoothly. But you can see there is a sharp bend from the ostia of the circumflex to the left main. This is a sharp bend. And I probably missed this portion of the left main actually. So I tried to put a stent. I was thinking that this is again it is a straightforward angioplasty. It is like RCA, which I did. But again, when I tried to push it from this point to this point, the stent was not moved forward. I have tried to push it hard, but if you see it, the balloon goes outside and a stent remained behind. So a stent was dislodged at this point of time. I tried to actually thus inflate it, the distally, and try to pull out, but again, it was not a successful event. and the balloon came out into the catheter and stent was dislodged in the left main coronary artery. I think you can see here. At this point of time, patient was having intense chest pain and patient was having bradycardia, pressure was dropped. Probably because we have already blocked the left main ostia, it was already diseased and another stent was dislodged, and that probably that compromises the flow of the coronary artery. So then medically managed, I medically managed with the vasopressor and the atropine, the patient was stable. So it is a short presentation. Just I wanted to tell you that what should we theoretically do. I tried to do it with these guidelines and try to catch the sinus. Somewhat is missing. Some maximum I have tried to grab. So if you have lost balloon and guide wire in the in situ, then you should pass a single marker balloon. Try to inflate it and try to retrieve the stent. This is the step number 1. If you failed in this step, probably I failed, as you see. So then if the second plan is to deploy the stent. If you find that if you dislodge stent in the matchable sizable artery, then you should inflate that stent to the appropriate site if your stent is dislodged in the matchable size artery. If your stent is and the vessel size is unacceptable, then deploy the stent in situ with the incremental balance site. If it is fail, then assess the site of the stent dislodgement. If it is proximal, then try to snare it. And if it is proximal or middle, then try to multi-wire technique to retrieve it. If you fail, then crush the stent. So this is the standard chart of the stent retrieval if you have dislodged stent anywhere. I have tried to do this, tried to grab maximum fluoro. I have tried to 1.5 millimeter balloon. I have tried to push this stent to the ostial circumflex because I think that the size of the ostial circumflex was around 2.75 like that. So my first aim to just push this stent to the circumflex ostia, but I was unfortunately unable to do this. Again, I have tried to pull it into the left main coronary artery, try to take it in the guiding catheter, but unfortunately it was my bad luck that the patient was having severe spasm in the radial artery. And again, it is very scary thing for me because there was some vasovagal element was there. I do not want to lose my wire from the stent. I tried to pull it out, but again, I was unable to do so. You see here, most of the time my guide is not supporting me to do any kind of work. Then again, I tried the multi-wire technique, and then I took 3 wires and make it take it in, entrap. Wanted to entrap balloon inside the 3 coronary that is guide wire. I just take a torquer on 3 coronary guide wires and rotating it, and I hope that stent will pull somewhere here. Somewhere the stent was pulled there, but again this technique was not successful. So again, this was the scenario after doing all that thing. I carefully analyze where there is actually stent. If the stent is not pinching any of the major artery that originates from the distal left main, then my plan was to just take the balloon in and the incremental balloon size, and then I sandwich this stent to the another stent. Because I have tried the snares, but unfortunately the snare I have, it was not worked at that time, and patient was not cooperative at all, and the pressure was not allowed to do me the various experiments. So carefully I analyzed that the patient was fortunately, the stent was fortunately at this point in which if I dilate this stent, then no major branch was compromised. So I took sequential balloon dilatation to inside this stent and make this stent that 2.5 into 10. So it was now a 2.5 stent that was in the left main coronary artery. Then I took Ultimaster inside the this stent and I put it this stent from the ostia. As you able to see this. So it was an stent crush technique, but it is not conventional stent crush technique because I didn't go from the side wires. And the reason because the patient was not allowed to do, give me some much time to do like that. I tried a wire taking the balloon, but somehow it is in between the strut of that stent. So I tried, that is very safe to give the crush the stent inside the stent. So I basically sandwiched this stent to the another Ultimaster, and then I post dilate to the 5 into 8 millimeter balloon at high pressure.
Okay.
And this was the final result. Pressure were picked up at the table, like 120 on the minimum dose of the vasopressor. Then I put the patient on the anticoagulant, and the patient was doing well as of now. It has been 6-month follow-up. So my take-home message is the stent entrapment and dislodgement in the left main coronary artery is extremely rare but a serious and life-threatening complication. The presented case demonstrated the balloon crushing or entrap and dislodge stent in the distal left vein in a hemodynamically unstable patient is a feasible, safe, and effective option for the management of the life-threatening.
Yeah. So, Dr. Swarup, I think we have got your take-home message. So, just one discussion point, maybe from Dr. Trehan, and we move forward because we are a little late in our schedule.
Sure, sure.
I think the case was very well managed, but a simple point which I think will be from me is that this is a somewhat longish left main. If you look at it, it's a longish left main. If you have a longish left main, and with that, if you have a reverse angle of the circumflex, then I think many times we are fooled by balloons which will quickly go over the wire from LM to circumflex. And once we try to take a stent, especially if a stent is a little longer than the balloon which you took, then I think we are likely to get into trouble. So one of the simpler things in such a situation is always anticipate that you are likely to get into trouble and maybe take your guide as deep as possible. So it is preferable to use an Emplas type of guiding, which can go into the left main. They can walk into the left main for a longer distance, or you can extend the guide with the help of a guide extender. And once your guide extender, like Guidezilla or whatever, it gets into circumflex, then the task is pretty easy. I think that is one message. Second is, once you get into trouble and like this, I think the first and most important thing is not do all these tricks which you did. First thing is have another access. In this case, which you did very late, I think go to femoral, take another guiding as big as possible and wire from LM to LED. Now, once you wire from LM to LED, then I think you have something with you just in case your patient is collapsing, anything is happening. Then from that guiding with a wire already from LM to LED, you can just either crush the stent to do whatever. So I think these are the two important take-homes, that be wary about a long left main with reverse angle and try and have an Emplas guiding, or extend your guiding with a guide extender. And you, in case you get into trouble, then have a femoral approach with the largest possible guiding, maybe 8 French, and wire from LM to LED. And then maybe whatever you want to do. And I'm quite surprised that you had a snare and you were not able to pull it out. I think if you had a snare, how did you pass the snare? You passed the snare. Can you just tell me how did you pass the snare?
The same guide. But again, the pressure was not allowing to do so, and there was intense radial spasm.
No, you passed the snare over what? Alongside into the guiding directly?
Yes.
Did you go over the wire or not?
Not over the wire.
So that is another
mistake. Then you cannot stand.
You should never, because if you take a snare which is not over the wire, then it is nearly impossible to catch the stent. You should have gone over the wire, which was already there. Then it is pretty easy. Even before the left main starts, your snare will tend to get over the stent. Yeah. So I think the message should not be that these stents cannot be snared. They can be snared, but you have to take the snare over the wire.
So let's move on to the next case. So there is a little change in plan. Dr. Sumit has to go for another session. So Dr. Sumit will be presenting his cases first of left main disease, easily dealt with one day and a nightmare another day.
Am I visible and are the slides visible?
Yeah, Dr.
Dr. Sumit, you can start with the other day.
Absolutely, sir. So that is the plan. Thank you very much to Dr. Mohit and CSI Delhi, and I'll just quickly go into the presentation. So this gentleman, unfortunately, I will have to say, was a 67-year-old male, a diabetic and hypertensive, who had a recent anterior wall MI and was managed at a peripheral hospital outside Delhi and was transferred here for further management to us. He continued to have post-MI angina. On evaluation, his ejection fraction was 40%. When we saw him, his vitals were stable, and the patient was planned to be taken up for a coronary angiography. So this is the shot, the first shot that we took. The access site was radial, and as we can see, it's like a trifurcation. There is a big ramus branch which is vascularly diseased. There is proximal severe disease of the LAD. There appears to be some disease at the distal left main in this view. And of course, the circumflex, though it is a non-dominant vessel, but it does have ostial severe disease as well. So I'll just go through the angiogram images because it's extremely important for us to focus in this case on the angiogram images, because that is what is going to, unfold the case as we go on. So though there was no sort of, wedging of the pressure with the diagnostic catheter, still the catheter was pulled out because there was a little bit of a scare when we saw this at the first shot that, it was an angiogram which had to be denuded with utmost caution. Again, same view, and this actually is the view which tells us, which shows us that there is a severe disease of the distal left main as well, along with the proximal critical disease in ramus, circumflex, and the LAD. Another view, and if you see in this view, the diagnostic catheter has gone a bit too far into the distal left main, despite the maximum precaution being taken. But anyway, the case went on. The diagnostic angiogram, the RCA was a dominant vessel which showed proximal severe disease and some disease at the ostium of the PD as well. So with this, the diagnosis was pretty clear. It is a critical triple vessel disease with significant left main disease. Patient was asymptomatic at the end of the coronary angiogram. The CT-based surgeon was called to the cath lab, and fortunately or unfortunately, this patient was the uncle of our consultant cardiovascular surgeon. He was busy in the case, so we just asked him to come to the cath lab to have a look at the angiogram and then, urgently talk to the family, because this looked like a case for coronary artery bypass surgery, and being relative of a cardiac surgeon, the opinion tilted in favor of a coronary artery bypass surgery. However, when he spoke to the family, the immediate family, they were not able to decide about whether, CABG should be done. In fact, we asked them that we should be putting in an IBP right on the cath lab table before shifting the patient out, even if they wanted to take some time to decide whether to go in for CABG or something else. So the patient was shifted to the cath observation area, which is just outside the, the cath lab. It's just one door away. And in cath observation, once he was shifted and he was hooked onto the monitors and all, within about 5 to 10 minutes, he started complaining of dyspepsia, so had some chest pain, and then immediately had a cardiorespiratory arrest. The resident was there, the junior consultant was there. I was immediately called as well. The immediate cardiopulmonary resuscitation CPR was started. Patient was intubated. The CPR went on for about 5-10 minutes. He was defibrillated for VF and immediately shifted back to the cath lab. So when we took him to the cath lab, he almost had a cardiac standstill. This is actually not the first shot. The first shot showed that it was a completely occluded left main. A choir was quickly passed into wherever it went actually, and I think it went into the LAD. Ongoing CPR was carried on, inotropes were escalated, and quickly a balloon dilatation was done to the left main. So we'd had some flow which was achieved with ongoing CPR and with the balloon dilatation, which quickly picked up, the cardiac activity picked up, the pressures also stabilized, and this is what we had post the initial balloon dilatation. Since we had some flow, the pressures were a little better. It was planned that before we actually went on with the intervention, we'll place an IBP, which was done. And then another was passed into the large ramus branch, and the left main LAD was dilated with a 2.5 millimeter balloon. So since the ramus also was a large vessel with significant osteal disease, it was decided to dilate the ostium of the ramus as well. And then drug-eluting stent 3x23 was deployed right from the ostium of the left main into the LAD. And this was deployed at about 14 to 16 atmospheres. The next shot showed that there was good flow in the LAD. The circumflex and the ramus were quite severely pinched, and since we had time, the patient was quite stable. It was decided that we'll at least open up the ramus by a 1.5 millimeter balloon, because that would probably be a little more useful to the patient in case the severe osteal pinching led to the closure of the ramus later on. So there was time enough to do a kissing balloon dilatation into the ramus and the left main LAD with appropriately sized balloons. And we'll just go back and show you this AP shot as well. Unfortunately, it's not playing. So with this, what happened was that the circumflex got occluded, and about 5 minutes were taken to wire the circumflex, which was not possible. And it was then decided that the ramus looked pretty good. The left main LAD stent was flowing well, and we would just leave it at that. And I think by the end of the procedure, after pulling out the wire, we did realize that there was at least some flow which was started to come in the left circumflex, and this is what actually the patient was left with. So we were reasonably okay with the result. Patient was shifted to ICU on inotropic support. However, despite the intervention, the IBP and the inotropic support, the arterial pressures were just not picking up. We did a quick echo check to see if there was everything okay. There was no pericardial effusion. The ejection fraction still remained at 40% despite whatever had happened. However, in arterial blood gas, which was done, showed the hemoglobin had dropped to 9 grams from a baseline of 13 grams. We did suspect that probably there could have been a retroperitoneal hematoma. The X-ray chest was also done in the ICU, which revealed opacification of the right lung shadow, as also a quick ultrasound abdomen was done, which revealed large quantity of intraperitoneal fluid collection. A needle aspiration was done by the ultrasonologist, which revealed frank blood in the peritoneal cavity. Blood was immediately requisitioned and blood transfusion was started. However, the hemoglobin kept further dropping, and it dropped to almost 5 grams per cent. This is all happening in the just 2 to 3 or 4 hours, post the intervention. He continued to remain unstable, and a few hours later, he had asystole, from which the patient could not be revived. So truly a nightmare in the cath lab is a nightmare when we lose the patient, because it's a nightmare for the patient, of course, the family, and for the treating doctors as well. The lesson learned from this, I would say, or to summarize, is that the risk of serious complications, including mortality in diagnostic coronary angiography, is extremely low in various series from 0.10 to 0.25%, but it does happen. And especially if someone has triple vessel disease or critical left main disease, and obviously the chances of it happening are more. Coronary angiogram in a high-risk lesion subset, when the initial shot shows that, like critical left main, has to be done with extreme caution. As far as possible, minimum injections should be taken to delineate the coronary anatomy. IVP insertion in cath lab should be stressed and done after explaining to attendants the critical nature of the disease, because sometimes that becomes a very, very life-saving kind of an intervention. Also, the quality of CPR is extremely important in an emergent situation. We have to minimize as far as possible trauma to the rib cage, because these patients are on high dose of antiplatelets and anticoagulated. So this was an unfortunate set of events. Losing a patient is never easy. But I thought I should just present this case to learn and have a fair bit of discussion on this. Thank you very much.
Thank you, Dr. Sumit. Really a brave call to present this case, and you did everything right as far as the coronary intervention was concerned, but unfortunately you could not save the patient. So what, according to you, was the cause of this bleeding? CPR or?
Yeah, so I thought once the patient crashed in the cath observation, that's not a very regulated sort of an area. The CPR is started in the enthusiasm. You start giving a CPR which is quite aggressive, probably not paying much attention to the fact that you're fracturing ribs, etc. So that probably led to a large pneumothorax, and that I think just seeped into the peritoneal cavity, and that was something which was sort of a very messy situation from which we could not recover.
So, any role of this Lucas, the automated CPR device, because that.
So unfortunately, Dr. Amitabh, there was no time, in this kind of a situation. The event unfolded in front of our eyes. There was VF. There was the anesthetist was, just trying to intubate the patient. There was ongoing CPR. There was a case going on to the cath lab that was made to hurry up so that we could, shut the patient with the cath lab. So it was a messy affair. I thought, the angiogram in this kind of a situation has to be done very, very crucially. We have to make sure that we don't get into that distal left main zone. We can, lift a flap there, and that is probably what really led to this catastrophe. Would love to have some comments from Dr. Trehan on this.
I think the case was managed in the best possible way, and but did you make any attempt to look for any other cause of retroperitoneal bleed?
Not really, sir. The patient was...
Because if you look at it, even though the problem started in the recovery period where it was initially a coronary problem, whether catheter related or may not be catheter related. And I think that was managed in the best possible way. The other thing which possibly could have been done in this case was just do as SKS rather than stenting from LM to LAD. I think that is, with this kind of a situation, you just do an SKS, wait for 10 minutes, the same stent which you took from LM to Ramus, then that can be crushed later on. Then you can imaging. So I think the first thing could have been SKS, because even a short time pinching of these vessels, sometime it, because if you look at it, the ejection fraction stayed 40% and the pressures are not coming, which we subsequently thought that it is not because of cardiac, it is because of something else. But after that, patient gave us some time. Did we make any effort to look for a puncture related RP bleed, or because pleural bleed getting through the diaphragm into the peritoneum, even though all these things are possible. But with cardiac massage, I don't think, unless you pierce the diaphragm, you don't really communicate a pleura with the pericardium. And
so no effort was made to find out whether it was a...
Because it is possible that there was some inadvertent stick at the femoral side, because we have had some unfortunate events in my hospital also, where something like this happened, and sometime little later after the angioplasty, we find that the patient is collapsing, and then we were able to salvage those cases. But my only point is, I think as far as coronary is concerned, you did the heroic job, and I think salute to you. I think you did it in the best possible way. But maybe because after the patient's hemoglobin was going down and the pressure was not picking, which were telling us that now this is only a blood loss. And fine, there was some blood loss in the pleura, but if you did a needle aspiration to peritoneum, then I think one could have possibly thought of something different, because rib cage injuries less often lead to bleeding into the peritoneum.
Yeah, that's a very fair thought, and actually that was just being planned to be the next step. But unfortunately,
patients don't.
The hemodynamics were so unstable that time just didn't come.
So hard luck, Dr. Sumit, but definitely a learning lesson for us. So let's move on to another left main dissection, my cath lab nightmares, by Dr. Saurabh Mehrotra. Dr. Saurabh, please.
Yeah.
Saurabh is looking as bright and as smart. We want to see your slides also.
Yeah, sir. Actually, I'm not able to get my slides, so I'll just share it. Just a sec.
Any problem or delay?
I think you can probably go on to the next presentation till I figure out as to how do I share my screen.
Okay, so let's go to Dr. Anunay Gupta, a complicated PCI rescued by imaging. Dr. Anunay, please.
Good morning, everyone.
Yeah. Anunay.
Yeah. So are you able to see my slides, sir?
Yes, yes.
Yeah. So a warm good morning to everyone. In the next 8 minutes, I will try to discuss a case of complicated PCI with 2 complications, and it was finally rescued by intravascular imaging. So this was a 47-year-old male who was non-diabetic, non-hypertensive. He was having a class 2 angina on optimal medical therapy. His angiogram showed a significant circ and RCA disease. And later on, he underwent a stress imaging, which showed a dobutamine stress echo, which showed a RWM in circ territory. So he was planned for a PCI to circumflex using a right radial route. So this is a baseline angiogram. As you can see here, the left main is short, and there is significant proximal and distal. This is the proximal, and this is a distal circ disease. So the plan was to put 2 discrete stents, one in the distal circ and another in the proximal stent. The procedure was done through the radial route. So first of all, we did a distal balloon angioplasty of a 2x15 balloon. Then the same balloon was pulled up and a proximal balloon angioplasty was done. We deployed a drug-eluting stent, 2.5 into 28 into distal circumflex. This was the result after distal stent. Then we deployed a proximal stent in the proximal circ. We did a 2.75 into 15 millimeter drug-eluting stent. This was the angiogram after the wire removal, the final shot which we took. And as you can see here, there is an abrupt distal vessel closure. So we thought that likely there is dissection at the distal end, and we recrossed the lesion, and we had a OCT. So we tried to do an OCT, but the problem was that due to pure distal flow, we were not able to visualize what is happening in the distal segment. We didn't have IVUS that day, so we thought that we will just cross it and stent the distal segment, and we tried to cross it with a 2.75 into 28 millimeter drug-eluting stent. But unfortunately, that stent came out of the balloon, and then we have to pull it back on the wire with a balloon, with a small balloon inside the stent, which was inflated, and then it was pulled back. While it was being pulled back, it got embolized in the brachial artery and was dislodged in the distal ulnar artery. There was no compromise in the flow. So we went ahead and hooked the vessel again. And finally, we decided that we'll take a smaller stent, and we were able to stent it with a 2.5 into 28 millimeter drug-eluting stent. The problem was that even after putting the third stent, there was still a suspected flap, and there was slow flow in the vessel. However, the vessel was flowing, so we decided that we will do an OCT now. This is an OCT run. This is the distal stent. There is a poor contrast clearing here, but the stent is well opposed. So there is a small segment where there was no stent. And this is the third stent which was deployed. As you can see, when it is being pulled back, there is a large intramural hematoma which has happened. And there was a small gap of 2 to 3 millimeter between the first and the third stent, where there was the entry point of that intramural hematoma. So OCT diagnosed a large intramural hematoma. You can see here this is a dissection at the distal end of the proximal stent. These are the dissection flaps. And this was a large intramural hematoma extending into a stented segment. And there was the distal end of the hematoma beyond the third stent. This is the dissection flap and the entry point of IMH. You can see in the horizontal 3D imaging. So finally, we took a fourth stent with an optimal overlap with a size of 2.75 into 12 millimeter. And as you can see here, we did an OCT again with a final angiogram. The vessel was flowing well, but instead of 2 stents, Now the patient had 4 stents in the circumflex artery. This is the final OCT run. Starting from the distal stent, well expanded, a small unstented segment. This is the third stent. Now we are coming to the second stent. Now that IMH entry point has been stented, so it has sealed off. So dissolution of intramural hematoma happened after the stenting of the proximal entry segment. As you can see here that IMH has now sealed off. The circumferential compression of IMH happened without any contrast clearing. So the take-home message and learning point from this case is that OCT helps in identifying and managing complication of PCI and is really very helpful. Dissection after balloon angioplasty may not be apparent on angiography and may extend with vigorous contrast injection. IMH can be diagnosed on OCT with a signal poor region within the media with a single intimal entry point, and the stenting will lead to a resultant resolution of IMH. Thank you.
Very nice case, Anunay. Just a few comments. Like when you deployed the third stent, so basically you were either thinking it's a dissection or a hematoma. Even in the first angiogram, it may give you some signs that it might be a hematoma, but whatever. Ultimately, you need to stent it. But then when you are deploying that stent, you will have to cover either the distal end of the proximal stent or the proximal end of the distal stent, because these are possibly the two entry points of the dissection, especially when you don't have an image where you can really, so probably a longer stent, or even if you are constrained by the anatomy not to able to pass a longer stent, it would have made sense to either overlap it from the proximal stent or from the distal stent, one way or the other, so that at least you have a 50% chance of covering up the entry point of the dissection.
Right, sir. The problem was that, sir, there's bigger stents for not going inside.
I understand.
So we have tried first, it got embolized. So we thought that first we will stent the distal part and just see on OCT what is the problem.
But unfortunately, you were not overlapping with any of the two stents, and you were lucky that you did not have a hematoma progressing on between the third and the first stent. Otherwise, you would have put a fifth stent.
Yes.
Dr. Trehan, any comments?
I think it is okay that you did an OCT and you showed beautiful images of IMH, but I think even angiogram tells everything. My interpretation, even from the angiogram where you have a stain outside the bounds of the vessel, I think it is an IMH. See, let me just tell you, intimal dissection, medial dissection, a medial dissection with an entry point and no exit point, which leads to a containment of blood within the vessel wall, which we call it an intramural hematoma. Type 1 dissection, type 1 perforation, they are all just the same thing. Just the same thing. And once you get beyond the vessel wall bounds, it's a type 2 dissection. You just stain a little bit of tissue around the vessel. And then once you start communicating with something, that is type 3 dissection. So all these things are in continuum. Whether you do an OCT or do not do an OCT, I think for any experienced operator, the things will be the same. The only thing is, once you start observing a stain, then I think you should be cautious that your stent length has to be long. Number one. Number two, once you know that your stent length has to be long, and if it is circumflex, and if you have already deployed a stent and that stent also has an angle in between, if you look at the first stent, it had an angle in between, then I think at this point in time, it is imperative, because even though there was a problem in the flow, but many times you just give a gentle inflation with a balloon, the flow will resume, flow will come. It may not be the best of the flow, but flow will come. And once the flow is there, then I think you should always give a thought that I can take a long stent rather than struggling around. And for taking a long stent, I think one should always think of guide extension. If you are not taking guide extension, then you are likely to run into trouble. And if you do not have a guide extension, then I think if I am doing the procedure, I would like to put 2-3 stents, small stents, rather than struggling with a long stent. Because struggling with a long stent can sometimes take your stent off the balloon within the artery, either within the circumflex or hanging partly into circumflex and partly into left main. That is a very, very undesirable situation. Then, so either have multiple small stents, which will of course will go, or preferable is to have a long stent And for delivering a long stent, especially if you want to do through a stent, I think it is extremely important to have a guide extension. And the other thing is that if you are suspecting a hematoma, which has one entry and doesn't have the exit, then what is very important is while you're deploying a stent, go very, very slowly with your balloon. If you are going very, very slowly with the balloon, what will happen is, like if you're deploying a stent, 2 atmosphere, 2.5, 3, 3.5, take maybe 3-4 minutes. What will happen is you will give some time for a hematoma which is contained within the vessel wall to exit out of whatever small little rent is there anywhere. But if you just blow up a balloon, it is possible that you close one end, and if you close one end, the other end was already not there. So now the hematoma will be only within the vessel wall. And what will happen is this hematoma will only slide. It will get shifted beyond the stent. So you have stented a long segment of a vessel, and then what you find is the hematoma is now transferring distally. So that is very, very and then of course people know how to manage these cases by cutting balloon or by puncturing with a stato wires and all, but I think they are very undesirable. The simpler thing is go very, very slowly with the balloon and give time for hematoma to express out. It is like drain out into the lumen of the vessel. I think these are my comments for this case.
Thank you, sir. Thank you very much. And thank you, Dr. Anune. Dr. Saurabh, are you ready with your case? Dr. Saurabh?
We can go to the next presentation and I'll present in the end.
Okay, so next presentation is Bolts Out of the Blue by Dr. Devinder Agrawal oblique Naveen Bamri. So, Dr. Devinder, you will be presenting the case.
Good morning, everybody.
Good morning.
I'm just sharing my screen.
Yeah.
Am I audible?
Yes, yes.
So this case is not from the coronary section, it's from a tower case. In the last few months of the series of the tower case, this was a case where the patient was having low ejection fraction. So coming to the case, is a 57-year-old male. He presented with the progressive worsening dyspnea, which leads to class 3 dyspnea. On evaluation, he was found to have bicuspid aortic valve with severe AS. It was Siever's type 0 bicuspid aortic valve, and also also had low EF, that is around 20% with a valve area of 0.7% centimeter square. Along with the severe LV dysfunction, he also had comorbidities in the terms of diabetic, hypertensive, COPD. He also had an ectopic kidney, and the discussion of tower versus Sauer was done with the family and CTV surgeon, because Euroscore was in the range of 7, and it was although intermediate risk with the age of 57. Still the family was not willing for Sauer, and they decided for tower, and so we took up this case and did CT angiogram for evaluation of aortic valve and aortic annulus along with the femoral vessels, and the annulus diameter, mean diameter of 27.5 millimeter, and area of 605, and LVOT was also large LVOT in this case, and the femoral vessel was quite adequate, and coronary heights were also adequate. So at these things, there was no issue about the tower. So these are the aortic root images from the CT. It's always somewhat elliptical aortic annulus with a mean annular diameter around 28 millimeter. We decided for the self-expanding evolute R valve for this case as to achieve a largest possible aortic valve orifice area, as the patient was young and any future deterioration of the prosthetic valve, still if the life of the prosthetic valve will remain good for future life of this patient. So this and aortic coronary sinus heights were adequate, 14 millimeter on the left coronary side, and the 18 millimeter on the right side. Angle was 38 degrees. So about the right, there was ectopic kidney which was arising from the left common iliac artery. So on the basis of this, we decided to have our vein access on the left side. Oh, this ectopic kidney was arising from the right common iliac. So we decided the main access from the left side, because if we have any accidental closure of this vessel, so supply to we have to put a stent graft here, so we can avoid the closure of supply to the kidney. So that's why the access was decided to the left common iliac and common femoral. And on basis of the mean annulus diameter, Z with perimetry, we decided 34 millimeter evolute R valve. So the case planning was, patient was taken for conscious sedation with transthoracic echo and 34 millimeter evolute R valve, and depth of implant was decided to 3 to 5 millimeter, and left femoral sheath was as the main axis, and we placed a balloon tip temporary pacemaker from the right internal jugular. We did a pre-BAV with the balloon size of 23 millimeter GMAT balloon, as the annulus diameter was around 24 millimeter. The dilatation of BAV was decided in view of bicuspid valve, horizontal aorta, and what gradient in this case was around 48 millimeter mercury. We used confida wire in the LV. So coming to the case now, with the micropuncture set, we took the left femoral axis. Then this the aortogram was done. The aortic valve was closed with the help of AL1 catheter with the straight tip thermo wire, and the check of the valve apposition and was checked on the fluoro, and it was properly opposed. We did GMAT balloon dilatation, the 2 millimeter balloon. The important event happened during the implantation, and the issue was that when we tried to implant the first time, because of the large LVOT, this valve got sucked in the LVOT. We have to retrieve the valve twice. You can see this is the first time the valve got sucked in the LVOT, and we have to retrieve it. And the same thing happened again, and we have to retrieve it again. So we had already used the 2-time retrieval of this valve, and because of the pre-dilatation of aortic valve and severe LVEF and the balloon aortic angiovasculoplasty lead to significant AR, and patient was almost collapsing at this point, and even needed brief CPR. We did rapid LV pacing to decrease the diastolic duration to have the whatever degree of systolic flow, and we were lucky enough that in the third time the valve got implanted at the optimal site with around 3 millimeter from the annular plane. And after waiting for around few minutes to have the good expansion of the valve plane, and we finally released it. So this was the post-implantation angiogram and showed good coronary flow and with minimal paravalvular leak. There was no conduction disturbances. Patient maintained the sinus rhythm, although there was backup in the right. On echo, the gradient was 2 millimeter mercury only, and this was the check angiogram of the femoral vessel. There was no vessel injury here, and we closed with the 2 pre-placed per close, and this was the angiogram from the another side, although the image is not very good. but there was no leak and there was no pinching here. So a brief take home from this patient that tower in patient with very poor LV function can be tricky, and because of the severe AR after the balloon angioplasty, patient can have rapid hemodynamic compromise. Rapid ventricular pacing can decrease the duration of diastole. And during deployment in patient with big LVOT, the prosthetic valve can be sucked in the LV, which happened twice in this case. And in patient with the severe LV dysfunction along with the severe AS, tower is indicated even in asymptomatic patient. So these are the take-home message from this case. I would like to thank the organizer for giving the opportunity to present this case.
Thank you, Dr. Devender. We kept on waiting for the bolt from the blue, but fortunately for the patient, there was nothing catastrophic that actually happened. But it was a nice case to demonstrate that.
Almost.
Yeah, I understand the patient was very sick and you had to act very fast in your final deployment. But that
even a brief CPR was needed.
I know. I understand. These patients are always very sick, so when these patients they are just on the verge of collapse. So, Dr. Trehan, any comment on the case?
I think this case was very well managed. As far as bolts are concerned, they had the real bolts. They tested that CPR, and I think all the time they must be having very high catecholamine. And I'm sure if you do their catecholamine levels during this procedure and put some holters on these operators, that will tell you well whether they really got the bolts or not. I think excellently managed case. Your balloons during BAV were slipping too much. And I think just a brief rapid pacing, maybe for 4 or 5 seconds. I know 20% ejection fraction, it is sometimes they don't tolerate, but a very brief rapid pacing, maybe 4 or 5 seconds, because you go up with a balloon for maybe 3 or 4 seconds only. And that tends to help you a lot, because a balloon moving in and out of the LVOT, even if you have a confida bar, sometimes these bars, even if they are confida, they tend to injure this. And as far as final positioning was concerned, I think there were some hiccups, but it was perfectly managed. Congratulations to you. Very nicely managed. Yes.
Thank you, Dr. Devender. So we move on to the next case, which is by Dr. Suresh Kaul, and his case is Bentall's procedure and a nightmare 10 years later, story of managing a 100% left main occlusion. Dr. Suresh, please. Dr. Suresh, have you unmuted yourself? We can't hear you. Dr. Suresh, we can see your slides, but we can't hear you.
So I've just unmuted myself.
Yeah,
First of all, I'd like to thank Delhi CSI for having given us an opportunity, and my respect to all the chairpersons and panelists and senior faculty, sir, for all we have learned actively or passively from all my heartfelt wishes. I would like to share this. It's not actually a nightmare. It was a difficult thing that happened to us for the first time after maybe around 15 years. And this was a Bentall's procedure which had been done a decade ago. And so it was a late Saturday evening and we were wrapping up our day. A 63-year-old hypertensive male landed in our emergency with excruciating angina, and his blood pressure was falling with a systolic blood pressure of 90. His ECG revealed a true posterior wall MI, and with AV dissociation, his echo showed regional wall motion abnormality in circ territory with a moderate MR, which was probably acute. And his history revealed that he had a bicuspid aortic valve and a post-aortic dilatation for which a Bentall's procedure had been done 12 years back. And a lima had been placed in distal LAD with some non-obstructive CAD and circ in right coronary artery. Patient had stopped anticoagulation on his own for a few months. As he was tossing around restless, we were thinking how to go ahead and what will be our route. We usually do our cases through the right radial. It is our default route, sir. And
what was coming to our mind, will it be easy to hook or cannulate the neo-ostia of the coronaries? And since there was no data or literature available on the internet, we were just thinking what we'll do. The family finally decided to stay back, and we get treated at our place. We work at Pathankot. It's one of the most remote cath labs in the country. And we made up our mind what to do and how to do. This was the ECG at presentation. You can see ST depression in the anterior precordial leads and AV dissociation. Our strategy was root right radial. The challenges that we had to face was entry into the aortic root and hooking the neo-ostia. We decided against assessing the lima because LAD territory on echo was perfectly contracting fine. So criticality needed quick and judicious solutions. So we went with a 5 French system, but to a 6F sheath up front. And this is what we got. The aortic valve was functioning, and there was a 100% occlusion of the native left main, where we also took a right shot. Now we decided to cannulate the left main with an extra backup, and as God was kind on us, it didn't take us much time. And we went in with a EBU and found a large chunk of thrombus there sitting on the distal left main, and no flow in circ as well as LAD. So we started with our workhorse wire, BMW over balloon support. We went on gradually in and started advancing our wire. And as soon as we're through, the flow to circ got restored. Now the problem was that we were not able to take our hardware down. That means our balloons were not going freely, maybe related to some kinking that usually occurs after Bentals in the ostia. And then there was some thrombus residue. We did a buddy wiring. This time we took another BMW and went in. And it was easier to pass in our balloons and dilate. There was, all the while we were giving thrombosuction runs, it is not shown here. And we went from 1.5 to 2.5 dilatations. And the lights, we kept on dilating. Circ looked good. At this point, we didn't think of, our main concern was to open the circ, which we had already reperfused. And finally, we took the wire out. And decided to give one last thrombosuction at the ostium of the left main. This was it. And as soon as we did it, we saw the LAD had got reperfused. We could see the septals all coming back. And there was around 40% stenosis in the proximal circ. Distal left main looked healthy. I think we had taken out most of the thrombus. And we decided we'll not stent it and leave it here, because we probably thought it is related to stoppage of anticoagulation. 2 hours after the procedure, this was the ECG. You could see ST segments had come back to baseline, and there was little PR prolongation, which at discharge had normalized. This was the aortic valve taken after 48 hours. Usually it was, this advice was given to us by the surgeon, who said that you've done a thrombosuction, please look for the integrity of the valve after 48 hours. So we did it, and the valve was functioning perfectly fine. This was a rare scenario which we have, encountered in our journey. And the take home: encountering coronary occlusions in 10 years post-valve replacement and Bentals procedure is uncommon. Taking good history on anticoagulation status can guide treatment strategies. Hooking the neo-ostia from radial route is challenging, but can be done with caution and care. Thrombosuction should be mandatorily performed in high thrombotic burden situations to avoid another implant insertion in these cases. And after PCI, the mechanical valve should be observed closely for its mobility and function. Thank you.
Yeah, indeed an interesting and a nice case. So, I think in your angiogram also the valve was looking a little suspicious. So maybe
Yes, sir. Absolutely.
your
Valve was
thrombosis.
looking suspicious when we started off.
Yeah.
It was not fully, open that time. But this observation was once we completed the case and did then we compared it, looked at after the thrombosuction and after 48 hours when we looked at the valve, it was definitely better than what it used to be before. And we had started him on anticoagulation on day 1 only.
Yeah.
So
And secondly, I think in your final valve fluoro, I'm sure Dr. Trehan would have liked me, if I was doing it, to be a little more end-on so that we see the valves much better. But still, we got the information that we needed. So, but the only thing was the LED. This patient had an LED, Lima to LED.
Yeah, Lima.
yes, he had a Lima to LED.
So, okay, so then you could concentrate on the LCX.
Yeah, absolutely. That's why we didn't even wire the LED.
Sure. So, Dr. Trehan, any?
My 2 points are there. I think if it comes to cannulating a left, I think especially if you want to intubate it and go deep, femoral, I think, is always better. I don't know why did you, because fine your radial, but there are situations when femoral will definitely give an edge. Second thing is, if you look at your case, you try to do a lot of work with your suction device, and you were trying to aim only reperfusing circumflex. But finally, the final run gave you a good reperfusion of LED also.
Yes, sir.
And according to me, everything could have been just done by having a femoral approach, having a guiding in, and almost nothing. No suction device. Just take a guiding a little deep in and apply a vigorous suction from the guiding catheter. And everything could, like, finally also you were trying to get suction towards circumflex. It sucked out even thing from LED.
Yes, sir.
And a guiding catheter gives you a bore which is far bigger than the bore of a catheter which goes through it, which also has a lumen inside and a wire lumen. So if you can take your guiding close to the thrombus only if you're going from the femoral. If you're going from the femoral, like you were able to wire into circumflex, take a balloon somewhere, wherever in small branch into circumflex, take a balloon there, anchor the balloon, now advance your guiding over it. Now your guiding will start walking into the left main. As your guiding is walking into the left main, that's a time you are making a contact with the thrombus. Once you're making a contact with the thrombus, just close your TUIs and everything. And now go with a vigorous suction. It has a tendency to suck out things from a distal circulation also. So I think, I'm not saying this, I think this case was managed in the best possible way. But my take will be that if I'm doing this case, I might, even if I'm a fanatic radial, might choose a femoral from the angle that I'll have a wider access. I may be able to use, rather than a 6 French thrombosuction device, a 7 French thrombosuction device, using a 8 French sheath in the femoral. And also in a specific scenario like this, where a thrombus is right close to the guiding catheter tip, I can even advance my guiding catheter tip into the thrombus and suck everything through the guiding catheter rather than needing a suction device. Finally, I think the case was managed in the best possible way. The best thing which you did was you didn't stent it. I think credit should go to you, because many times once we do a task, we have something which is slight residual lumen or irregularities there. So we try to make it better by just inflating a balloon there. Inflating a balloon and putting a stent there, I think at times is undesirable. And this is one of those scenarios, and managed in the best possible way. Congratulations to you.
Thank you, sir. Thanks, sir. And he has finished 1 year of follow-up, sir. And
doing
he has
such
finished.
cases at small places like Pathankot is all the more commendable.
Thank you,
because,
sir. Thank you.
Even in the best of the high volume centers, I think most of us would have found it very difficult to handle. Congratulations to you.
Thank you, sir. Thank you.
Yeah.
Thank you, Dr. Kaul and
Thank
Dr. Trehan. So we move on to the next, which is by Dr. Indrajit Monga, hanging RCA stent crushed and new ostia created. Dr. Monga, please.
Good morning, sir. Thank you for giving me this opportunity, sir. Thank you for the organizers. Sir, are my slides visible, sir?
Yes, yes.
Sir, this is a rare case, sir, which I did in July, sir. Sir, this is a patient of a 52-year-old male, non-diabetic, but he is a case of polycythemia. His hemoglobin always used to remain around 18, and he's a smoker too. So he presented with inferior valve MI to a peripheral hospital with complete heart block on 11th of July, and he was liaised there with TPA. But other thing was that since he was having complete heart block, so the operator there had done TPI, but they didn't do primary because patient was not willing from that hospital. So after that, ST was resolved and a patient returned to sinusitism. So post lysis, he was shifted to our hospital, and the TPI was also removed there. But what we noticed when the patient came to us, he had a large hematoma on the right groin because with TPI in situ, he was thrombolized. So he had echo EF of 45%, inferior posterior valve was akinetic, but it was thickness was preserved with mild MR. And patient had developed on the 13th patient developed post-infarct angina. So he was taken for rescue PCI. So angiography findings I will be discussing, sir. And BP at when he was taken on the table was 90/56, and inotox were already started, and IBP was kept standby. So this initially the case was not started by me because I was on leave at that time, but my fellow who was freshly passed from this thing RNR, so he had come and he was doing this case, sir, initially. So this was the left angiogram, sir. There was not much significant abnormality. Only LAD has got some bridging and some distal plaque is there. And sir, this was the RCA shot. First, with the root was radial, and this is Tiger catheter. So there we don't notice much of the osteal disease because it has a side hole. So, but there is a diffuse disease from proximal to the mid RCA, and some distal RCA also had got some eccentric plaque. So when he put the guide, he immediately noted that there was osteal damping. So he put a TPI from the left side, from the left femoral. And again, since patient was on anticoagulants, so he had to take a lot of puncture for that. He had to struggle, and then he put a TPI. Then he tried to hooking with this guide, with JR guide. Sir, but there was slow flow, and there was bradycardia noted. So what he did, he changed the guide to the side hole, and this was again 6-French GR guide. He didn't do a femoral, that should have been the preferred approach. So, but he continued with the side hole catheter, and filter FC was crossed with little difficulty. And then he took a small balloon, 1.25 balloon, and he started dilating. Then he took a bigger balloon, 2 to 12, and again he continued with the dilatations. But here proximal part was also dilated. But what mistake he did was didn't dilate. He didn't try to dilate the ostium, but which is significant. Even with side hole, you see, we don't have any reflux from the ostium, sir. So this was the mistake he was doing. And secondly, his wire was almost not parked in the distal enough. It was almost in the proximal distal RCA. It has to be parked a little more distally, so for better support. So these were the two mistakes what he carried on. And then he took another mistake he did. He took a long stent, 2.75 into 44 millimeter depth. He tried to cover the entire lesion with a single stent. So he tried to park this stent at near the bifurcation because there was a early PD. And then what happened, sir? He was this was the just cine before deployment, and in between there's no cine, but this is the cine after deployment. So in this, what has happened that mid RCA, which was there was a lesion at the beginning, it has not been covered. Stent approximately 15 mm to 20 mm stent is hanging inside this thing, and wire is also out. So these were the mistakes. Firstly, noted that operator was inexperienced, but still these mistakes cannot be this thing should have been corrected, sir. Then radial SS was used in restless patient with the patient was already on inotropic support, poor wire positioning with an inadequate guide support, and long stent was taken despite inadequate bed preparation without dilating and cutting the osteal disease. He had realized there is osteal disease. He had taken side hole catheter, but he didn't dilate and cut the ostium. And long stent was deployed without fluorovisualization, which got deployed half inside the aorta and half inside the RCA. and dissected segment in the mid RCA, which was there after dissection was there, which is remained uncovered. So patient further developed severe angina and hemodynamic instability, inotox were upgraded and panics resulted. So, and in the meantime, his guide got disengaged and wires were also lost. So I was called, I was at home, so immediately came, sir, and joined the case, and anesthesiologist also joined, sir. So this is how we, I did the bailout, sir. So first I lined the guide with due precautions and crossed the wire through a strut. Since the guide was in the radial place, I already taken that 2 into 12 balloon, and with that I aligned the guide over a strut and then crossed from the strut, and with the loop in the wire, I parted as little as possible in the RCA. So then ostium that from where this thing I had crossed the strut was dilated with a 2 into 12 balloon, and then, sir, I dilated the mid RCA also, which was uncovered at that time, so that flow can be restored. And then I dilated with a bigger balloon, 2.5 into 12 balloon for this thing, for the strut part, sir, because I have to carry a stent through it. So after this, this was the after guide manipulation and alignment. This was the a fluoro I took, sir, to see the this thing. Now, sir, further dilated the mid part and took a stent 2.75 into 26 integrity stent, sir. And first I wanted to fix the dissected part so that my flow can be restored. This was a dissected part, so I covered with the stent 2.75 into 26 resolute integrity. Sorry, 30. So this is the stent I deployed into this part, and with the overlap portion of the previous stent, and confirm the position, and then deployed the stent, and then overlap portion was dilated with the same stent balloon, and then again this stent balloon was pulled back, and through the new ostia which I had created from the strut dilatation, and after crushing the previous stent, so there also I dilated this stent at high pressure, stent balloon. So after that, this was the flow like after dilating. So still flow is restored and patient is now a little stable. So, but this hanging strut can cause a lot of problem and can cause stent thrombosis. So I wanted to fix this part and wanted to be sure that it doesn't land up with the stent thrombosis. So what I did, sir, I took a 3.5 into 12 balloon. First I dilated the proximal point and then opened with the same balloon, I opened the struts also and then used a 3.5 into 12 NC, stent, and then parked it here, and with in some part in the ostium, so that I wanted to create a new ostia. And this is how, after deployment of the stent of the 3.5 into 15 Rhines prime, and then dilated with the same balloon, stent balloon, overlap portion also was this thing dilated, and then. So this is the ostial flaring I did with the 3.5 into 15 balloon. And this is how, after this, I created this new ostia. So after that, I checked with the guide, sir, and this thing, guide was engaging perfectly into this thing. And then I removed the wire, and then I said, took a signature, and after disengaging the guide first, I wanted to be sure that will I be able to engage it for the subsequent requirement, if any. So in that time, then I disengage purposefully, and then I re-engage it. So and now I'm sure that now I will be able to do second procedure also in case something happens. So this was the final result. So just to summarize, sir, this was the initial this thing on this thing, and then after balloon dilatation, there was a dissection. And unhooked guide, hanging struts, this was a complication. And then we crossed through the strut, and this first dilated with a 2 into 10 balloon with a deeply parked wire. And then mid RC stent was deployed. First strut was opened with a bigger balloon, then mid RC stent was deployed. And then new ostia was created after this thing dilating this thing with a bigger balloon. And then we created new ostia by putting a stent and then this guide was hooked and rehooked, and just to be sure that we'll be able to do the procedure again. So take home message from this case was ostial lesion should be dilated adequately and cut prior to stenting. Why should be as distal as possible. Guide support is always the key. Switch to femoral in restless patient, and stent inflation should always be visualized to, and it has to be done under fluoro so that we can see whether it is coming behind, back or not. Never lose patience and never lose wire in a complication. Undeployed stent hanging in aorta still can be crushed, and neostea can be created, like in this case we have demonstrated. And intravascular imaging, if available, that helps in complication management and stent optimization. Sir, I'm through with my case, sir.
Thank you, Dr. Monga. Your JC actually had a baptism by fire, and but we all learn, we all evolve through this only. So I think it was a nice case. So Dr. Saibal, any comments on the case?
I think it has been well managed. I mean, he has shown all the basic mistakes that were committed. And I think that was a good way of salvaging, passing through the immediately coming and passing through the stent struts and then dilating the strut and then addressing the distal part of the lesion and finally crushing the stent. That was a good thought process with a stent hanging half in the aorta and losing the access. So that was a good approach to get the wire into the struts and dilate and then crush this thing. I think sir may add something.
Dr. Monga?
Sir, thank you, sir, for the comment, sir.
Did I evaluate your thesis?
Sir, I think, yes, sir. Yes, sir.
Not think. You should remember it because your thesis was delayed. Your thesis was delayed, and I got many calls from that Billorani from PGI. Huh? So your presentation is as lucid as was your thesis. Very nicely presented case.
Thank you.
But I have a couple of comments to make. One is the smashing technique, which you were saying as flaring. That is not a flaring technique. That is known as ostial smashing technique. In this technique, what you try to do is you try to smash the stent, which is getting out of the vessel into the aorta, but you show smashing only in one plane, that is superior inferior plane. You ideally have to do in both anterior posterior as well as superior inferior plane. And for superior inferior, fine, you can push and pull your guiding. But for anterior posterior smashing, you have to rotate your guiding clockwise and counterclockwise. Number one. Number two is, I think you should have done this smashing even before you put the second stent. That should have been done even when the first stent was crushed with the first entry into the right coronary artery. Number one. Number two, what if you just left the ostium of the RCA just like that without putting an additional stent? Because I don't think the second stent has done anything great over the first stent, because we already had an excess of stent. And once you went into the coronary artery, surely you cannot enter the right coronary artery distal to the ostium. You will enter proximal to the ostium. So you have some part of the stent still within the aorta. If you still have some part of the stent within the aorta, I don't think you will be adding too much by putting another stent. And we should not forget a hanging stent is a nidus for thrombus. And putting any extra metal at that juncture, I think for me, could possibly have been avoided. And to be very sure that your stent is still hanging outside is should have done possibly some kind of imaging. Because first, once you entered with a wire, it is just like this. You take a wire from wherever it goes to the coronary artery, it's fine. It is possible that the wire entered the stent, while the stent was in aorta. It is also possible that the wire walked alongside the stent and entered the stent inside the artery. Are you getting my point?
Yes, sir.
Your wire can enter from aorta, or your wire can enter from within the coronary artery. And angiographically, you can never be sure. But if you had the facility for imaging, and if imaging tells you that you walked into the stent outside the ostium, then I don't think there was any need of second stent. And I think just crushing the first stent and should have been okay. If given a choice, you would like to crush the stent downward or upward?
Sir, not sure, sir.
I think downward is better.
Downward apparently is better, but if you want to hook this vessel again, upward shifting is much better, because you tend to take your right coronary guiding catheter at the sinus first, rotate clockwise, and then pull it. Because now you can't take your guiding catheter. If you want to come and hook this vessel again, you want to do right hooking as you normally do, is go to the sinus, rotate clockwise, and then pull it. That then that inferiorly crushed stent will interfere. Anyhow, nice presentation. Congratulations to you.
Sir, Dr. Girish, sir.
Yeah.
Sir, for the smashing technique, is there any new balloon for it? Because I have seen.
Yeah, there is an osteoflash balloon which is in the literature for last more than 10 years. It's commercially available for last 8 years. People elsewhere are regularly using it. This is a balloon. This is what you can understand is like I know a balloon, same balloon,
Yes,
which can inflate first distally, then proximally, then in the center. This osteoflash balloon is two balloons. One is a balloon which will walk into the coronary, will have a size according to the coronary. The other balloon is proximal, which is almost like a circle. It is like it's a balloon which has the dimension like 10 by 10. So you take this balloon into the coronary artery and you put the marker at the ostium. Now you start inflating. What will happen is the balloon which is inside the coronary artery will inflate to the size of the vessel, will fix that balloon there. And the balloon which is hanging outside is like a circle, usually 10 millimeters. It will now expand, and in fact, this tries to flare or make the funnel of the stent the best possible way. I think it's a custom designed osteoflash. This was initially used for renal arteries. Then it was used for LM ostium, but now it is used at many other places. It's a very handy, very simple balloon, and in fact, a lot of people just regularly finish their ostial stenting. They finish their ostial stenting by an IVUS with chroma to show that your stent has a little bit of hang in the aorta. And after the chroma shows you that the hang is there in the aorta, then use that osteoflash balloon to flare up the part of the balloon which is hanging.
But you get the best funneling, sir.
Best funneling is the
best funneling. Thank you, sir.
So let's move on to the next case of Dr. Saurabh Mehrotra. Dr. Saurabh, your slides are visible. You can start.
Right. Good afternoon, everyone, and sorry for the delay. So I'll be presenting. My patient in question is a 77-year-old female. She had class 3 angina and with a normal LV function with ECG showing suppression V3 to V6. She presented to another hospital where an angiogram was done. And as can be seen from the first angiogram, there's a tight lesion in the ostial LAD and probably some plaque in the distal left main. The circ looks okay. But as you can see in the second angiogram, there was a dissection in the left main caused by the diagnostic catheter, and there was staining there. However, the angiogram continued. You can see the staining of the left main, which was caused by the diagnostic catheter, with a tight lesion in the ostial LAD and some amount of plaquing in the mid LAD, proximal LAD as well. So after which, probably the hospital where the angiogram was being done, they realized it was a left main dissection, and they said that the patient needs a bypass surgery, which is not available at that hospital. And the patient was referred to PGI with ongoing chest pain. Since the patient had a left main dissection, so we took up the patient for an coronary angioplasty. And soon as we hooked the left main ostium, we knew there was a dissection because we picked it up on an angiogram, on reviewing the angiogram that was done in a private hospital. However, the moment we took the femoral root and the contralateral groin was prepared for an IBP insertion if required. And as soon as the left main was hooked, there was hemodynamic compromise with bradyarrhythmia, the antegrade flow stopped, and the patient collapsed. And IBP was and CPR was started, and I took a Fielder XC wire and tried to cross into the LED into the true lumen. I was able to do it successfully, and I took a drug-eluting stent 3.5 into 30, and because I wanted to restore the antegrade flow, because the patient was hemodynamically compromised, I decided to first stent the left main to LED without taking care of what the lesion in the mid to distal LED was. I immediately stented the left main to LED with a 3.5 into 30 DES to restore the antegrade flow. In the meantime, one of my colleagues also, because the patient was having bradyarrhythmia, besides having given atropine, and since the venous sheath was in situ, we also tried to put in the TPI. However, after we stented the left main to LED, the antegrade flow was restored and the patient became hemodynamically stable. Thereafter, it was not very difficult. We first post-dilated the left main to LED stent, did a pod with a 4 to 12 mm balloon at 20 to 24 atmospheres. Thereafter, we optimized the left main with a 4.5 into 12 mm balloon at high pressures. And then, since there was a lesion in the proximal to mid LED, we fixed it up with a drug-eluting stent 3.5 into 26 with overlap. There was slight amount of haziness in the left main at that point of time. So we further post-dilated it with a 4.5 into 12 mm balloon. And this was the final result. We decided we couldn't do an IVUS earlier because the patient hemodynamically decompensated the moment the guide was hooked in. So this was the result. There was slight amount of pinching at the ostial LCX, but the patient was stable at that point of time. So we could have done a functional study to document its significance, but we decided to leave it at this stage, at this point in time. And we did an IVUS to see whether, because everything was done in a haste, and so we decided to follow it up with an IVUS. First of all, we wanted to see what that haze in the left main ostium was, which was fixed up with a 4.5 mm balloon, and the final result was clear. And also we wanted to see whether the stents that we have implanted were well optimized or not. So as can be seen from the IVUS images, the stents are well opposed to the walls. The MLA in the left main was 13, while at the LED it was around 9.29. And this was the IVUS run that we took post-optimization. And as can be seen from the, we haven't, so that's where we start getting the stent. And as we can see, the stent is well opposed to the walls, and it was a well optimized angiographic result from left main to LED. With an adequate MSA achieved post-stenting. And so we are out there. So to conclude, iatrogenic left main coronary artery dissection is rare with an incidence of around 0.07%. It could be spontaneous or iatrogenic. Important causes of spontaneous being connective tissue disorders, atherosclerosis, hypertension, old age, bicuspid aortic valve or a calcified aorta, as well as coronary artery anomalies. However, in the index case, had an iatrogenic coronary artery dissection, probably due to diagnostic catheter manipulation or deep intubation with forceful contrast injection. And because there's a loss of antegrade flow, it does result in hemodynamic compromise requiring prompt action. Several treatment options have been described in literature, including conservative management and ranging from PCI to CABG. This is a well-known classification of coronary artery dissection, and it's well known that type A and B are generally benign, while dissections ranging from C to F need to be treated. There are two important classifications which are well described, one being the Dunning and the other is the Esther-Hardy's classification for dissection. Though it is difficult to manage these patients conservatively, but can be done in hemodynamically stable patients with A and B dissection. However, since the index case had hemodynamical instability, so PCI is the preferred option in this group of patients because of considerations of time and instability. And the most important step while doing a PCI is to put the wire in the true lumen. Of course, coronary artery bypass surgery is recommended in patients where the aortic involvement is 40 millimeters or more from the coronary artery ostium. And the review of literature has described an observational study of 38 patients with left main dissection, out of which 1 died, 6 were managed conservatively, 14 were managed with stenting, and 17 with bypass surgery. And it was seen that on follow-up of 5 years, there was no difference between the 5-year morbidity and mortality rate in patients with bailout stenting versus bypass surgery. Thank you.
So very nicely managed, Dr. Saurabh. This further emphasized the fact that whenever you have this type of a situation, just put a wire wherever it goes and try to restore the flow. So my question would be for my fellow panelists, like in this type of a situation where we have done a crossover stenting from left main to LED, and you have a very I mean a reasonably good size LCA. How comfortable will we be without doing a final kissing balloon, or at least opening of the ostium of the LCX with a balloon?
As far as the literature is concerned, opening up the stent struts in all cases is not really recommended. First of all, you need to know whether you need to have a distal cross, proximal cross, and ideally when you do a kissing balloon inflation, you don't have to have a distal cross of a wire. And it is always better to have OCT guided distal cross so that you have kind of optimized your stent result. Because if you're doing angiography, you tend to recross through the proximal or mid struts, then probably the end result would not be as good. And there is not much literature whether this final kissing actually really helps in the long run or not. However, there are certain case reports which do show that if these patients land up with a restenosis in the ostial circ, there are probably multiple holes, which are multiple areas of stenosis which are created in the ostial circ, which are difficult to manage, which can be prevented if a kissing balloon inflation is done at the outset. But moreover, another important caveat in doing a kissing balloon inflation in the beginning, in the absence of a functional study, would be that you really don't know whether you have a link at the carina or you have a link-free carina. And then there are studies which have shown that if you have a link at the carina and you do a kissing balloon inflation, it doesn't really help and tends to worsen your result. So, then an optimal way of doing this case would be that after we have stented from the left main to LED, first of all, we do a functional study to see whether the ostial circ is actually tight or not. Then we do an imaging study to see whether there's a link-free carina or a link type of carina. And then if there's a link in the carina, then the Japanese have described a technique called the balloon push method, which is the ideal technique to do a kissing balloon in these cases. So, considering the fact that the literature is kind of 50-50 on whether it should actually be done or not, there are no guidelines so far. And there's so many caveats as to whether there's a link-free carina or not, and all those other things which require imaging, which adds on to the cost, we decided to leave it as it is and see how the patient responds and follow up.
Yeah, sure. Your case is like, it was just a general question for.
I think Dr. Trihan, we could hear from Dr. Trihan as to what he actually feels about it.
Sir, you are muted, sir. You are muted, sir.
So let me first talk about the link-free part. I think because link-free and the carina with link, I think that this is a thing which you can assess confidently only if you do imaging, and that too maybe only OCT. And even I was usually not able to tell you. But and even if it is even if there is a link in the carina, still you may be able to have good result provided you have entered through a bigger cell, because link is a partition in the cell. So if you are entering through a smaller cell with a link at the carina, you are in the worst position. If you are entering through a bigger cell with a link at the carina, you are in a still better position. But if there is no link, you are in the best position. And how to know is, I think for such a big circ ostium, if you pass a wire, no matter whether the wire goes proximally or distally, if you take a small new balloon, which is like 1.25 or 1.5, and if your inflated balloon walks through a cell, then you are reasonably ensured that you are through a link-free and a wide carina, a wide cell carina. Okay. Or the other thing which we can do is, which we commonly do is that you wire the circumflex ostium, and after wiring the circumflex from wherever it has gone, take an old NC balloon and see whether it can pass through it. If your old NC balloon can walk through into the circumflex, then I think you are tasted the pudding. You are sure that you are walked through a Karana and a cell, which is, even if it has a link, it is through a wide cell. And then I think you can reposition the struts so that they don't come in the way, because Ronnie has shown that if you have the cells, you have some stent material across the ostium of the side branch, they will provide a scaffold over which a very thin membrane can grow. That may not be seen angiographically, but that can produce hemodynamic problem, and it can result into so-called Achilles heel circumflex problem, which are sometimes localized to that point only. I think that was too much, but let me just talk about the basics about this case. I think when we talk about femoral versus radial, we all know that for doing left coronary artery interventions, radial doesn't give you a very good guide support. We know it, isn't it? Amitabh, do you agree with me that if you're doing radial versus femoral, then the femoral gives you much better guide support? However, for the diagnostic, especially using Tiger, they are more aggressive to get into the left coronary. And like Sumit showed his case, there also Tiger was used. In this case also the Tiger was used. I think the diagnostic catheter, which is aggressively intubating the left coronary, can injure the coronary. And I think the way Saurabh did the case, it gave him the opportunity to present this case. But let me give you a trick by which you will not have an opportunity to present the case, but you will not secrete adrenaline. I think in your case, Saurabh, you should have started the case with a wire already hanging in aorta, because you know that there is a dissection. Once you know that there is a dissection, any guiding catheter from femoral, if it tries to hook the femoral, and then you try to pass you push the contrast through it, the jet of the contrast will also be more forceful. And that is what can result into an arrest like this. I think it is much better to have a wire hanging in aorta. Don't let your guiding enter the coronary artery. Your guiding still close to the ostium. You just try and take your wire from your previous angiogram, which you have it. Just try to wire wherever it goes, as Amitabh was saying. But I think in this case, preferably, you should definitely try to aim into LED also. First wire wherever it goes, but finally, I think you should have a wire in the LED. Once your wire is in the LED, then maybe you are entitled to pull out the wire from aorta and have your guiding walk into the coronary artery and see what is happening where. I think, according to me, if you are encountered with this kind of a case in future, don't go with your guiding straight into the coronary artery. Do not let the guiding walk into the coronary artery. Have a wire which doesn't let the guiding walk into the coronary artery. Try to wire into one of the branches from outside, from the guide tip outside the ostium. And once you have entered any branch, try and ensure that you still walk into the LED first. Once you have walked into the LED, then I think you can pull out the wire from the aorta, you can advance your guiding, you can take shoots, and after that, then the life will be comfortable. Of course, you will be debarred of presenting a case in meetings like this.
Thank you. But does the size of Judkin's left will help in choosing the size? Like if you have dissected the artery with 3.5, dissection is in the cranial aspect.
Not 3.5 or 4, but short tip Judkin will help you. It is not 3.5 or 4. It is not the curve. It is a short tip. Short tip will prevent your guiding from entering into the coronary. Yeah, short tip is just a very small part of the secondary curve beyond the. So short tip guiding, we used to use short tip guiding catheters in short left mains when we didn't want the guiding to aggressively get into one of the branches.
Yeah.
They are nowadays not available on the shelf.
So in defense of Saurabh, I think in his case there was a difference between the angiogram and the angioplasty. So maybe the thrombus was already being formed in the dissected left main. So I mean, he was the patient was almost on the verge of collapsing. Even.
But whatever, I think if because
your point is taken that you should have a wire so that you are
because you took the patient living, you took the patient with the rhythm, you took the patient with pressures, and everything happened after your guiding went into the coronary artery. So I think you have to prevent your guiding from getting into the coronary artery, and the shoot which you take from a guiding which is into the coronary artery is also more injuring, as was elucidated by Saurabh. So if you are not entering the coronary artery, you are not injuring. Your shoot is also not injuring. And this will still permit you to wire your circumflex and LED. I think that's a very important point to be taken home.
So with that, we end the session, and it was a very it was quite a learning session, and I thank all the panelists and all my fellow experts. So let's move on to the next session, please.
Thank you very much, sir. The next session will be taken by Dr. P.K. Goel. Over to Dr. P.K. Goel.
Okay, I think we are nearly an hour late. So this is a session on CTO, and this is a case-based discussion, case-based presentations. So we have 10 minutes to each presenter. There are 5 presenters. I understand one presenter is absent. Dr. Viveka is not there. So whatever it is, we can go to about 12 minutes maybe. So I think without wasting time, let us start the case-based presentations and cover the subjects that they have asked us to do. So I think the first talk is by Dr. Arun Kalyan Sundaram. Arun is there. Where is Arun? He's logged in.
Yep,
Arun,
I'm here.
are you there?
I'm here. Yep, I'm here.
Okay, great. So
yeah,
we will have the first talk by you, which is the hybrid algorithm for CTO. Okay.
Yeah. So my understanding is that this is also going to be kind of a case-based interaction.
Yeah, well,
so
that is what the session.
All right. Super.
Added. Yeah.
There we go. Okay. Good. Let me just make sure. Okay. Good.
I'll just make a small comment. I was overhearing the last talk about radial versus femoral and complications. I think this is all probably related to how conversant the operator is on radial and femoral. So I don't think one can really feel that femoral may be better than radial. Anyhow, this is just my thought. Go ahead.
All right. So, okay, guys, can you see the slides?
Yeah.
Okay. So, thank you again for the opportunity. I'll try to stick to 10 minutes so that we have more time for discussion. So there are various algorithms that are out there, and I mean, hybrid was the original algorithm, which really, I mean, I would say was like the granddaddy of all this, which kind of said, all right, how do we approach CTO systematically instead of just going through, 1,000 or 2,000 CTOs before getting expertise like some of the panelists here have. So this was an attempt to really kind of understand how to do this. APCTO subsequently came out as a second algorithm. The idea was to kind of tailor it more to regional sensibilities with a little bit more emphasis on parallel wiring. There are some subtle differences, but the goal really was to try and have a more systematic approach. And I think Dr. Goel and Pratap are also on in the global attempt that Manos is trying to put together as a global algorithm that should be coming out soon. So I'm just going to show one case because I think time is short. Here is a case that of a LED CTO prior attempt, and you guys can kind of see it there. I'm going to let it play once more. So proximal cap is pretty discrete. Distal cap's at a bifurcation. Not a great branch, but it's there. Pretty short CTO segment. So really something that I thought is going to be a slam dunk. Famous last words, right? You never know with CTOs. I'm like, all right. So that was kind of the plan. There was a bit of calcium there, but thought, all right, didn't look horrible on the outside angiogram, but I was kind of appreciating more as I was doing this. So my plan, based on the anatomy, really was to try antegrade wire escalation. If that didn't work, to try retrograde. If that didn't work, to go and do ADR. So this was kind of the whole goal of this. And again, initially, like I said, started with antegrade wire escalation. There were no good collaterals from the right. So what I did was essentially just put another guide. I already had access there, just kind of wired and got a microcatheter into the dominant collateral, and just really left it there for so that I could have good visualization in terms of target. And I'm a big believer, it's like, don't take shortcuts in CTOs, however easy they might appear to be. So antegrade wire was attempted, and for the life of it, this turned out to be an impenetrable cap. This was actually not in my hospital, where I do have an Astaro 40, but the most penetrated wire that they had was not even the Hornet 14, but a CP12. But it just wouldn't penetrate despite wedging in the microcatheter and other usual attempts to increase backup. So now that's the challenge here. And you can, now I'm also appreciating more of the calcium here. So really try to do this. Oh yeah, they had an 820, I guess. I did try that. The problem I kind of thought was, either at this point I go retrograde, or I'm going to circumvent the cap itself, which is really base. Decided to go retrograde. Again, given time, I'm not getting into the details of the discussion. So at a Caravel, that's a SUO 03. Done. You are in the LAD. So once this is done, got the microcatheter for without much effort. That you can see the Caravel just slide in here, here, here. You're in a good spot, right? So I thought, all right, short segment retrograde wire escalation should work. This should be great. Didn't work. So then I just switched really quick to a guide extension reverse card, because I already had a guide extension there to increase backup. So I just got so for those in the audience that do not know what a guide extension reverse card is, essentially you have a guide liner, guidezilla, telescope, whatever, wire, balloon, create a space, retrograde wire gets into the same space, followed with the microcatheter getting into the guide extension catheter. Now came the other problem. Did this, could not get my retrograde microcatheter into the, wouldn't cross this segment. So I thought, all right, now let me make this antegrade. So we did a tip-in, which is the retrograde wire gets into an antegrade microcatheter. So again, the key is to have solutions to a lot of the problems. So this was done without much effort. You can kind of see it enter the antegrade microcatheter at this point. And then once again, antegrade microcatheter also was not advancing. This was despite guide extension catheter and everything, right? So now we got a problem. And by this time, the retrograde Caravel was kind of just really not handling well. It was because of the calcium. So I switched to a new fine cross retrograde. And then I kind of said, all right, I'm going to just take a rotablation. But then finally, when I did call for it, they said, well, the rota thing wasn't working at this point. So I'm like, okay, now I have a big problem. I have this rind of calcium that I can't circumvent. So what I did was try to do external cap crush. Again, for those that are not familiar with this, this is not that case, but this was another case that I did where essentially what you do is if you get a wire across, you can't cross with anything else. What you do is get subintimal, crush that part from outside the space, and then you change that area enough so that now your microcatheters, etc., can navigate. Now, this is obviously a different case where I just did this for the circ. So I did do external cap crush, but lo and behold, I still could not get my microcatheter antegrade or retrograde. So I decided at this point, all right, so there you can kind of see, I mean, so, you got this here, you have subintimal space, and it still wouldn't, even though you balloon this area, it still wouldn't let anything pass through the true lumen. So I kind of said, all right, I'm going to use the retrograde wire as a marker. And then I just decided to do, so here, I mean, I know where exactly I am. I got another wire down here. And then I just got a Stingray balloon catheter further down. And now, again, this is a slide that you guys have probably seen. This is the view on the left is correct, view on the right is wrong. But I mean, this was easy. I got a target. I know exactly where to go. And boom. So I just kind of used that. There we go. And now the rest was fairly straightforward because that area, which was kind of, which I just couldn't cross, I basically kind of went into the vessel wall and re-entered, so that now we've just created a new path. So that's the workhorse wire getting in. And I mean, the rest was just PCI. Did IVUS to understand where I was, et cetera, and that's kind of the final result. And then, in fact, I had to use an OPN to really try and optimize the MLA, et cetera. So the key point is, really have a game plan. Don't go and say, I'm going to just try and dabble and figure out as things go. If you don't plan, you're going to fail. Or it's a high likelihood you're going to fail. So, and be ready to switch strategies. As you can see, I went through multiple options in this case. And obviously knowing and being conversant with multiple techniques is going to help you optimize your chances of success. Thank you very much for your attention.
Thank you, Arun, for that nice case. I think the basic point that you conveyed was that you should understand when to switch strategies, and you really have to switch fast, and you need to know how long a strategy would work. So, and that is what the hybrid algorithm probably talks about, when to use which strategy and how to switch between strategies. So we have the 3 strategies with us. And Pratap, you want to say something on the hybrid?
No, actually it was nicely explained. That case was wonderful.
Yeah.
Only point is, Arun, actually, when you just take a wire or balloon down in the subintimal track, do you think there is a chance of a perforation chance is there or not?
Nope. No.
Just one question, Arun. I recently experienced a situation where I did cross the Stingray wire into the distal vessel, but that was shocking and it was really frustrating. And then I trapped the thing in the guiding catheter and was pulling out the Stingray balloon trap because over the wire system. I wonder how the damn thing, the wire came out. At the end of the day, yeah. It was a similar case. Everything done finally ended up in ADR, because most of the ADRs that we do are salvage ADRs where you're failed otherwise. And at the end, having crossed it successfully, when we were pulling it out, the Stingray balloon, I don't know if you've experienced that. I don't know. So the balloon wasn't leaking, sometimes the balloon could be leaking, or, the pressure wasn't enough, but we were seeing that the pressure was damped on the guiding catheter. I wonder.
So, I mean, 2 questions. One, you trapped it with an adequately sized balloon, and number 2, watch it as you were pulling it back. When the wire was coming back, you would have seen it, right?
Well, before I could watch it and control it, it was out.
All right. Yeah, that's frustrating.
So
I mean, that's yeah, because it can be, especially when you go across a couple of tissue planes, that can be a very high resistance area. So as you're pulling it, it's absolutely imperative that you watch it under fluoro, because there is a chance the wire comes back. And then there are solutions if the wire is coming back. But sometimes, I mean, I know early on, this has happened, and I'm sure it's you're not the first person to whom it has happened. But the key is just to try and really watch it, especially if you've had a difficult stick, because that means you've gone through a lot like this.
I get that point. Maybe that is right.
Yeah.
Okay. All right. So we can have some more discussion at the end if there is time. So we can go to the next talk. I think Pratap is going to give the next talk. Pratap, you're going to talk on image-guided interventions.
It's respected chairperson and Delhi CSI. Just I'm going to. Okay. This is actually the case 1. It is in a TVD, CTO, LED, and RCA. Circumflex, actually, the OM is stented. You can see that wire. There is a CTO segment in the LED. It's an antegrade CTO intervention. We put the wire down. What we have observed is actually the wire is looking like outside the vessel, and the lumen, what I felt was the green colored one. The guide wire is actually filter FC with the microcatheter coming down. I was really shocked. The Corsair was the microcatheter here. When the wire was actually taking an angulated projection, I was thinking whether I'm in the right position or not. So, but the Corsair, and when they shifted to the Gaiasec, and the wire gone easily down, but there was a gap. I was thinking I am outside the vessel. In these situations where actually probably it is subintimal in the proximal part, but the wire went down as Arun told. So you have to do a balloon dilatation, and then I was down. This eye was actually in multiple segments. You can see totally in the lumen. Even though what I have seen actually, it is definitely the wrong path, which I was thinking to track, but it is not definitely, luckily, my wire did not go. The situation is we did a pre-dilatation, and then we did a stenting from the proximal to the distal, and we got a very good result. And this was the result, and we got 300 ml of contrast use. and 41 minutes of fluoro and 6,000 gray. The second case actually in Antrobal MI 2007, and angiogram shows single vessel disease, and this patient's angiogram is like this. There is actually an ambiguous entry point and good retrograde collaterals and attempted antegrade already. So we thought this is actually the part. We can have an excellent retrograde collaterals. So what we thought is actually we will go retrograde. The fine cross actually in the PDA, you can see the PDA, there is a fine cross here. So we try to pass with the Suhatri wire, but you can see that it is actually taking an angulated way, but it has gone down. When I took the wire into the retrograde path, I tried to pass the wire into the distal LAD and taking the microcatheter into the septal distal part. And with that help, I just took the wire into the antegrade. And again, I took the wire into the diagonal and actually the D1. With the help of that, I could push my microcatheter up. I took the microcatheter up, then I tried again a field FC, definitely not able to cross. So when I could not cross, the option is to change over to the stiff wire or reverse cart antegrade. But I just tried a reverse Gaia second wire. But when you can see properly, you can see the wire is actually out of the lumen. When I just injected, I can see that actually wire is out of the lumen. When the wire is out of the lumen, we thought we would do a guideline of assisted entry. And with the keeping a wire under the septal artery, I tried a Miracle 6 wire. With the Miracle 6 wire, I could enter into the vessel. Actually, it went into the guideliner. So it's a guideliner assisted entry of the retrograde wire into the right system. So we did a balloon trapping and a fine cross to the antegrade catheter. We exchanged to the RG3 wire. And now the fine cross, actually, you can see a fine cross in the PDA. We removed the fine cross. We put in 1.5 millimeter in the RG3. That is a normal process we do. In the same time, I told my colleague to look for an IVUS, actually take the IVUS. We did the vessel size, stent length, and how many stents are required. So in the meantime, I tried to take a 2 millimeter balloon when the IVUS was assessed, but I could not take a 2 millimeter balloon. But I saw the angiogram. It was a totally subintimal entry in the postero-proximal part of the lady. So I did an IVUS. I was actually seeing the distal vessel was in the true lumen, but you can see the false lumen in the proximal part. Actually, across the septal artery, it was totally in the false lumen. So this is actually the system. The guide wire in the proximal part, actually it is proximal to the septal artery. So what actually can do is actually, if you dilate this part, what we will, ideally the green color should have been the entry point, but the entry was in a different way. By the subintimal stenting in the proximal LAD, you can do a subintimal stenting in the CTO, there is no problem. But we will lose the major septal artery, which I don't want to lose. So the only way to get out of this problem is actually keeping the retrograde wire as a marker wire, try to push the antegrade wire. What I did is actually I've taken a fine cross with the field FC into the antegrade system, and then I kept the retrograde wire like that. And with the microcatheter almost reaching up to the septal artery. With that septal, I tried a Gaia second to cross the wire. And the Congress Pro 12 only crossed. And fine cross pushed distally. And then we did a 1.5 millimeter balloon. We did an IVUS again. It was totally in the true lumen. We saw this is a vessel diameter. We got a dilatation here. Then the next other part is actually we are in the true lumen now. We just tried to cross the diagonal, but diagonal crossing was not possible there. Then balloon inflation, final IVUS, before putting the stent again to understand what is the length of the lesion. Then the 4 millimeter stent proximally, 11.61 and 18 point. So the LAD was 3.4 millimeter, which is 16 millimeter. Distal lumen size is 3. And we did a 4 millimeter in the proximal, that is LMCA to LAD. And another one is 3.5, 3 into 15 in the proximal LAD. And this is the final result. We did an IVUS here. And this is a contrast we used is 360 ml, 11 gray was used, and the fluoro time was like this. So two cases of CTO, one is antegrade, one is retrograde. Success of this intervention is due to imaging. IVUS helped in understanding the true lumen in both cases. If IVUS was not done in the second case, it would have ended in a complication resulting in perforation, and the long-term result would have been worse. The length of the lesion and sizing of the stent also can be guided by imaging. This shows examples. Actually, these examples show the importance of imaging in situ intervention. Thank you. Muted, you are muted.
Dr. Goel, you're muted.
Okay. Thank you, Dr. Pratap, for the nice cases. I was just wondering, in the first case, is it that there was some other overlapping vessel which was there, and maybe you were trying to outline your wire on that vessel?
Probably correct, but actually I'm telling that in different projection I saw that the wire is actually taking an angulated entry into the LED. Probably that is correct, but I was thinking that since it is an angulated, we would have tried in the other way around and we would have lost the septals totally. That would have been a dangerous situation. But when the wire gone down, I thought, okay, let it go. But once it is gone, it was going very smoothly down. So I was really shocked that where I am in the right track or not.
Dr. Pratap, if I may, beautiful case. I mean, actually, I really love your second one. I think it, for those that are interested in CTOs, I think it really emphasizes the importance of being meticulous. I mean, he could have easily just been, all right, I'm already done. I just want to stent it and get out. But, taking the time and effort to do the right thing, really nice demonstration. Beautiful case. Thank you.
Okay, so I think I have to do the next presentation. So Arun and Pratap, you could take over.
We will share.
Okay, so I was supposed to show some cases of antegrade and retrograde. Now, 10 minutes I thought was too small to do all that. So I have decided to show you two antegrade cases, especially there's something new that I want to show and share with everyone in the antegrade wiring. So maybe it may be helpful. So the first case is LED CTO flush with diagonal. So that's how you see it in two views. So you have a flush occlusion, you have a septal coming out and a diagonal on the other side. Okay, and that's the RCA showing collateral filling is through RV branches. So not much scope for retrograde truly in this case, because the branches are all RV branches that are filling. It's a non-dominant type RCA. So what we plan here was IVUS guided entry into the CTO stump. So that is a part of antegrade PCI, a CTO PCI. So I'm going to show you that. So what we did was we take IVUS into the side branch, that's the diagonal, and have another wire on another microcatheter in the main vessel. And with that, if you see, so that's the still frame of the flush occlusion with the diagonal of the LED stump. And that's the length of the occlusion through bilateral injection. You can see that about 25 millimeters, if I'm not wrong. And this is maybe something good for the beginners also. They would like to see how it is exactly done. And you see that in the IVUS picture on the right, you see the branch, the occluded vessel. And in that occluded vessel, when you will see it run, so that's the occluded vessel seen here on the left IVUS picture. And here you actually see the wire has already entered. I'll just show you once again. So there it is. You see the wire is inside the occluded segment. So you know that you are right. You have crossed the occluded segment correct. But one has to understand that the IVUS will only tell you at the point where it is bifurcating. Beyond that, again, you could get subintimal. So now you have to use your angiographic widths again. So that's the point where the IVUS stops, and then you move the wire ahead. And then whatever is happening, and there was a bifurcation at the distal cap, and we somehow lost that. We were subintimal there. And then I think I used Crusade and a parallel wire, and finally I could get it. And so we used a parallel wire. So there was, and it was a long segment subintimal. So with a parallel wire, I think we had crossed this. The steps in between, and so finally went on to parallel wire, and with a parallel wire, with a Gaia 2 wire, I think we could cross. So that's the standard antigrade technique that we were doing, and we are still doing. And I think we'll just run through these in the interest of time. And finally, the parallel wire succeeded here. Okay, further progress of the wire, contralateral injection, confirming it. And then balloon dilatation, completion of the case. And then there was a PLV that was also done. The second case, this case actually is the one which I want to show you a new concept that I have just talked, which I have just published. So this patient had a RCA lesion here, a dominant big RCA, and the LAD is filling through collaterals. Again, it's a LAD occlusion, and the occlusion is right from the ostium. There is some trickle which seems like a microchannel flow. So what we've done, we finished the RCA, of course, we've done that. And because the LV is normal, so we need to do the LAD. So now here, as you see, we have a bilateral injection, which is the basic for any CTO. And in that, so what you see is that the large RCA is now nearly normal. There are septal collaterals to the LAD, and there are some suggestions of microchannels towards the LAD. And the distal LAD filling on frame by frame is definitely retrograde. So I thought maybe this we will do antigrade because there's maybe some microchannels. So that's the microcatheter and the antigrade wire. This is the XT that is being used, and it is moving forward. And gradual wire maneuvering under contralateral guidance. So we are trying to move forward gradually, step by step. But it is moving, this is cranial view, it's moving a little anterior, which suggests that maybe it's going towards a diagonal. And yes, it is going towards a diagonal, but when a situation like this happens, I usually leave it, I continue in that diagonal, confirming that retrogradely you are seeing that it is not haywire and it is in the diagonal. So we confirmed that and we continued. And then further advancement into diagonal. And then once you are well in the diagonal, you change to a workhorse wire over a microcatheter, do some balloon dilatation. Sometimes a native LAD will open up even otherwise. Else, if it doesn't, then you can use a Crusade type catheter to get into the bifurcation stump of the LAD. So we did that. But now what you see is it opens towards the diagonal. It opens towards the diagonal, but there is no real stump of the LAD, and the LAD is still filling through collaterals. So now at this stage, I don't know. Well, I can again use the IVUS and see where the LAD is. But then what I did was I looked in another view, and the same wire in the other view is looking as if there is a LAD at that bend point, because the anatomy you have to understand. At that bend point, I think it's the LAD which is continuing with the distal vessel, which you see here in the contralateral injection. So I took that as the point and guided, put a Crusade there and used the Gaia 2 to enter into the LAD from this point onwards. And well, we did enter forwards, and it looked pretty right, but cross-checking from a contralateral injection suggested the correct direction, but probably at the distal cap, I was a little subintimal. I was not in the exact plane. And now what I did was, this is the biplane angio, which we usually do. And now I would like to tell you a little about this 3D analysis, the 3D wiring algorithm that we have just developed. And this has been published in no less than JSCC. So it is, so I think I'll show you that. And the concept is, once you get subintimal, the wire is in the subintimal space. It could be in any of these 8 positions. We can divide the space into 8 positions. And the wire tip independently could be in 8 independent positions in that circle of that wire. I hope you get that. So 8 into 8 makes 64 combinations. And considering those 64 combinations, now you see I'm showing you the still frame of the position of the wire at the distal cap. In the LAO view, you see that the wire is certainly in front of the true vessel, which is here, because the other front vessel is the septum. So it is in front. The wire tip is almost end on. You can't really say it is anterior or posterior. In the RAO view, you see that it looks almost in line with where the vessel is going, but the tip is truly posterior. So what you need to do is, this is the algorithm that we have worked out, which is available on the article in JSCC. So correlating these two wire locations by the two sides, two views, you know exactly the wire is located in space and where the tip is located in space. And then you know which direction you will be able to penetrate to enter. This will work at the distal cap. And you need a wire with 1:1 torque control. And what you need is wire with pushability. So Gaia 2, Gaia 3, these are the two wires that work very well on this. So in this case, in LAO view, the wire looked in front, and in RAO view, it looked overlapped. So it is placed rightly at right and anterior. And in the wire tip, similarly, is placed right and posterior. Now, once we know that the wire is right and anterior and the tip is right and posterior, so you know how much to rotate. This is again an algorithm, nothing very great, but you have summarized the whole thing in the paper. And so what you do is you have to rotate 90 degrees counterclockwise, and your tip will become posterior in LAO and end on in RAO. And if you do that, you will cross. And this is exactly what we did. And now you see on the moving frame, it's sometimes difficult to replicate what exactly is happening there on the frame. But we did that, so the tip is getting end on here in the RAO, and we're trying to make it posterior in LAO. And once it hits the right plane, you will go. This is exactly what you try to do with your hands also, but sometimes you feel you're rotating it in the right direction, but it goes haywire miles away in the other. So this algorithm helps you in directing the wire. And that's the 3D algorithm. Some Japanese, Okamura actually talked about in 2016 on an experimental study, but no one really could use it much. So with that, we could complete the case. And so that's what I wanted to show. And then finally you do a stent and whatever. So case shows antigrade wire crossing, crusade to handle bifurcation, and finally the 3D wiring algorithm to enter the distal cap. Thank you. I think we'll stop there. So
actually, Goyal, that was an excellent demonstration. Actually, when Okamura presented the same thing in many forums, but I think no one could understand.
No. But today you have understood. Today I have done the same thing, but today you have understood. And I'm telling you, and that's the reason they accepted this. In fact, Mortirino, what's the name, David, who's the editor, he told me you've made it so simple. So I think we must publish it. So
that is what I'm telling. Actually, Okamura tried his level best to make people understand.
No one could understand.
And actually,
I have made people understand this.
Minimum, actually, I'm just telling you, he presented minimum 3 forums where I was also there, but I could not understand what he was telling. But he was also telling the same thing, but in different angles.
But you must give me credit that at least now you understand what I am saying.
I'm just telling you that is the most important point. Actually,
yes.
Whatever is practiced is actually seen properly and understanding properly. That is actually made by you. And you took enough time to understand these things and make it acceptable to us. That is what I'm telling. It is incredible.
Thank you. So
amazing work, Dr. Goyal. That is very true. I have to agree with everything Pratap just said. That's great. Strong work. Congrats on the publication.
Thank you, Arun. Okay, so now we go to the last presenter, Sanjeev. So you have a great job to explain us all the tools and hardwares. Okay, I don't think you'll do it by case. You could do that also by case.
I think Sanjeev, you are muted.
I have to unshare the screen first. Aja, these guys can take over, huh? Great. I have not unshared my screen, but someone can take over.
Is my screen visible?
Okay, yes, thank you.
Yeah, thank you, sir.
Yes, it is. Go ahead, please.
But to be very honest, after all the masters are presenting the cases, case-based scenario, I thought it is best for me to summarize a CTO toolkit, but I don't have a case-based scenario, but because most of them have been present. So I'll try to be very lucid, and this presentation is basically meant for those who are in the beginning of their CTO PCI. I'll try to summarize what toolkit should be there. So the equipment for the CTO, one of the most frequently asked questions about the CTO PCI program, especially early in their programs in the learning curve, is what equipment do I really need? And many operators would like to have everything available, but that's not the practical way, because you need a cost, you need a space, you have a space limitations. So we usually need to categorize into two, what we must have and what is good to have. And most importantly, we must familiarize with the equipment that we have, and we need to cover for the complications when it happens. So broadly, it can be categorized into these 12, and in the 10 minutes time, I'll try to cover each one of them as early as possible. So vascular sheaths, we have a dual access, and what we must have is a 6 to 8 French size sheaths for the femoral and radial 6 French, but slender 7 French sheath will be more good to have, as well as the long sheaths as well, because long sheaths provide you better support, and particularly when you have a tortuous anatomy at the access site. So you need, in difficult cases, sometimes a micropuncture and ultrasound guidance and a white bore. As far as the guide catheter is concerned, two important things, the shape and size. And what is more important is you should have a coaxially aligned extra backup catheters, both for the left and the right. And for the right, you have a JR or AL. For the right, it is the extra backup catheters or EBO. So these are the catheters that you must have. And good to have is if you have a 90 centimeter long guides, but you can always, to externalize the guide, you can have a shorter guide customized in your lab. Side hole, you can always make it. And these are the ways to make the side hole or shorten the guiding catheter. As far as the overall combination is concerned, most popular combination is using a 7 French or 8 French antegrade guide and a 6 French through the donor vessel through the radial combination. But it is very important to understand the compatibility of the device, because with 6 French, like you can have 2 fine cross microcatheter, maybe a balloon to trap and a microcatheter. But when you need multiple, you might need a 7 French and an 8 French guide. Guide extension catheter, very useful. And I think Dr. Pratap also showed that use of an extension catheter can always be very useful in using a reverse scar technique, or sometimes also to get into the donor vessels. So basically these guide extension catheter, they have a stainless steel pushing tube and a distally a tube which can accommodate. And you have to understand that these are 2 French shorter than what the outer diameter of the guider is. And these are the GuideLiner, GuideZilla, and GuideOn. And we normally do a trapping of these wires, but a dedicated trap liner catheter and trapper exchange devices are also available. Microcatheter, they are the very integral part of the CTO PCI, as well as the over-the-wire balloon. Which one should we have, microcatheter or over-the-wire balloon? I think given a choice, you should have both, but microcatheter has an added advantage because it gives you a better support, increases your tip stiffness. They're more resistant to kink, and they can be, help in increasing the penetration power of the guide wire that you're using. So to get into the CTO, you use a workhorse wire. You push your the GuideLiner distally to that, and then you can use your dedicated devices. So these are a couple of microcatheters which are very useful to start with. You have a Corsair, which is basically a channel dilator, and the advantage is it can be torqued and rotated and twisted to reach distally. Caravel, again, this is very useful for, it has a very low distal tip profile. It can be pushed forward, and also rotated, but not for aggressive rotation and advancement. It's very good for the channels and the septals. Fine cross, this is an advantage. It's a Brady catheter. Again, it has moved by pushing, sometimes takes a rotation, but advantage is the tip is 1.8 French, so it is easily tracks to the micro channels. These are the other which are not available in India. The micro, which is the smallest tip with the longest length. Turnpike is very useful, particularly the Turnpike Spiral and Gold. Currently not there in India, but they can replace the Tornus catheters when used. These are the other catheters which are available. Venture microcatheter, again, very useful. These are angulated one, but you have to have a vessel size of 2.5 millimeter distally. And basic uses of this angulated microcatheter is you have a situation like, you need to go to the Circum Austria, very angulated bends. This prove very useful. Alternatively, there are supercross microcatheters which are angulated. You have a 45 degree, 90 degree, and 120 degree, which has a similar role. Dual lumen catheter, as all of you seen that in the cases that were done, it's very, very useful. What we have here is a Crusade and Sasuke about to be launched. They have 2 lumens. One is for the rapid exchange and for the over the wire. They're very useful for the parallel wire for technique for the penetrating CTO cap, which is very adjacent to the side branch, and again re-entry into the true lumen and sometimes in the septal wiring. So these are the microcatheters which you must have: the Corsair, the Caravel, Fine Cross, and it's good to have the other ones. So when you have, in the antegrade approach, you have a less backup, not very calcified CTO lesions. You can manage easily with the Fine Cross, but you need a more backup support. I think Corsair Pro is very useful. For the retrograde, again, when you need a septal crossing, Corsair Pro or Turnpike is okay. For epicardial, you need a Caravel wire. Support catheters, not much in use. These are the center cross and the multi-cross. Center cross is a large lumen through which you can introduce your microcatheter, and the multi-cross are, there are different channels, 3 channels at different 120 degree apart, where you can use the wire for a parallel wire technique. Prodigy catheter and Nova Cross, these are catheter support catheters, which helps you to centralize and help in penetrating. CTO wires, most often you must be hearing this. A lot of CTO wires, there's an evolution from 95 to 2018 to a various type. Broadly, you can have a soft tip, intermediate tip, and a hard or stiff tip, which can be tapered or non-tapered, which can be polymer based or non-polymer. And these are the huge list of the CTO wires, which I'm not going to go in details, but here suffice to say that if you want to, cross the micro channels, wires like Fielder XT are very useful, or even otherwise, when you are going for a knuckling technique, again, Fielder and Pilot 50 or 200 are very useful. For penetration, you need the stiffer wire, the Gaia, the Conquest Pro, and Pilot. Sometimes it is good to have the Hornet wires, which are very stiff. Collateral surfing, Xion Black, and the Fielder XTR. For externalization, definitely you need an RG3 wire. And sometimes you need an extra support wire like in, Grand Slam or Ironman in a difficult situations. Spatial balloons, these are, balloons which are meant to crack the stiff lesions, like the non-compliant Nick Nano or the Nick Nano Hydro, which is 0.8 and 1.1 profile. There are various other CTO balloons which are as low profile as 0.75. It's good to have, but not a must one. Again, OpenNC is very good balloon that we must have when we have dealing with a very fibrocalcific lesion. And to modify the plaque, there are other plaque modification balloons like the Scoreflex, the NC Alpha, AngioSculpt, and the Wolverine balloon. They are good to have, and actually the FlexStorm or the Wolverine and the AngioSculpt, I think you must have. These are other balloons which have come up to modify the plaque. And for the ADR antegrade dissection reentry, it can be a wire-based knuckling, where you have a larger subintimal plane, but a controlled dissection reentry can be done with the Crossboss and Stingray. And both Dr. Arun and Dr. P.K. Goel sir has already demonstrated this. So Stingray and Crossboss, definitely you are planning for an ADR technique, you must have. particularly the Stingray LP balloon, which can be used with a lower profile catheter. Sometimes we need an atherectomy devices, and of course, orbital is not preferred much in CTO if your wire is subintimal, but yes, good to have a rota. And for a difficult where you do not have anything to cross, an excimer laser is be a useful technique. Imaging, Dr. Pratap had definitely shown the utility of IVUS, which is used for localization of the proximal cap to direct the wire within the CTO segments. Dr. Goel also had shown this, and then confirm the position of the wire in the distal lumen. For stent optimization and to know the vessel, of course, both IVUS or OCT can be used, but otherwise IVUS has an edge over OCT in CTOs. Uncrossable and undilatable lesions, again, we usually try, once the wire is through, we try to cross with the microcatheter, and there goes the algorithm. If it doesn't work, we can try for the anchoring technique and the small balloon, which I already discussed. And finally, we have the tornus. And if nothing works, possibly if your wire is through, we can go for a laser or rotablation and then subsequently exchange. These are a couple of, if you have, it's good to have. This is further balloon microdilatation catheter, very low profile, very unique for this kind of situations. Tornus, again, you try to rotate and cross through, rotate clockwise and again unrotated anti-clockwise. These are good to cross this kind of lesions. So good, you should also have tools for managing the complications, particularly your perforation kit should always be ready. Pericardiocentesis, sometimes you need coils and injectables. If you don't have anything, a macerated fat for the distal lesions can be good. And of course, the covered stent, that is Graftmaster. Snares sometimes for the wire externalization or even for dislodge tools is very useful to have. And hemodynamic support in very complicated cases is must. This is IABP, Impel or Tandem Hurt. So to conclude, CTO toolkit, you don't have any universal checklist. It depends on the personal preference and experience and availability. You must stock appropriate tools for your practice, know how to use them, minimize and consolidate the me-too options. We need to prepare for emergencies and worst scenario. And the success of CTO PCI lies in the mantra, we need to have a right tool, do it at the right time and the right way. Thank you. So this is the last frontier to be crossed. Event horizon in sight, but the journey ahead before the last frontier in PCI conquered is very long. Thank you. Sir, you have to unmute yourself, sir.
Thank you, Sanjeev, for the trying to summarize the tools that could be needed to do a CTO PCI program. Well, I would only like to add in the sense, it's better to have limited tools, but you must understand what each tool can do. So you must have an equal understanding of like which wire can do, which microcatheter can do, and to how to handle that wire, how to handle that microcatheter. And and have one selection of, it's not that you have a wire of one make today, another make tomorrow, and a third make day after. So it's better to have one make wires in different gradations, whichever you want to choose. So something like that would probably be good for the beginners. And even I think for experienced people, always good to have tools which you are conversant. Yeah. Any other thoughts, any questions, any points, Arun, Pratap, or anyone else? I don't know.
Right. I think that was a nice summary, Dr. Sanjeev, and thank you again. And I fully echo what Dr. Goel had said in terms of, be conversant with a couple of wires, but really use, try and achieve mastery over them. Don't, and try to minimize the Me Too products, right? I mean, I'm not going to pick anything here, but I mean, if you don't need, and especially because, space is often limited, you don't need Geizhiller, Guideliner, Telescope, like, pick one, get comfortable with it. Likewise, I mean, have different wires in different categories, like have some penetrative wires, have some wires if you're going to knuckle, etc. You don't, it's just, you're absolutely right. I mean, get really comfortable. The differences are often subtle between the products and the Me Too products. So pick one and try and use it a lot.
Yeah. Okay, I think if the organizers would agree, we can close this session because we started late. It's already pretty late. Is that okay?
Yeah, sir. So this was the last session for this CardioPrime Hall. Now the paper presentation will be in the main arena area from 2 p.m. onwards.
I give it to the organizers now. Thank you.
Thank you. Bye.
Thank you.
Okay.
Thank you.
Thank you, guys. Bye-bye. Bye.